The subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. We had a very instructive field hearing, our first in Harrisburg last week, on the one-year anniversary of the signing of PPACA. What we heard about the health reform law's cost on Pennsylvania alone was chilling. Governor Corbett stated that after the Medicaid expansion had gone into effect, roughly 1 in 4 Pennsylvanians would be on the program. According to Acting Secretary of the Department of Public Welfare, Gary Alexander, Medicaid currently accounts for 30% of the state budget. That is more than all but 2 other states, Illinois and Missouri. And if PPACA is fully implemented, that percentage will double to 60% of their state budget by fiscal year 1920. This is simply not sustainable for my home state or any other. And the numbers don't look much better for the federal government either. On March 18, 2011, CBO released its preliminary analysis of the President's fiscal year 12 budget. CBO estimate of total spending on coverage expansions in PPACA grew from $938 billion last March for fiscal years 2010 through 2019 to $1.445 trillion for fiscal years 2012 to 2021. That's a 54% increase in federal spending. As you may remember, President Obama, when he was running, promised his health care plan would cost $50 to $65 billion a year when fully phased in. CBO, however, projects that the real cost of the coverage expansions will be $229 billion in 2020 and $2,045 billion in 2021, 4 times the level of spending that President Obama had promised. And what about the jobs PPACA was supposed to create? Then Speaker Pelosi stated in February of last year that the new law would create 4 million jobs, 400,000 jobs almost immediately, end quote. Yet, as Mr. Elmendorf told the House Budget Committee last month, he expects the law will cost 800,000 jobs by 2021. That may be because the law contains perverse incentives for businesses not to grow. Small businesses are hesitant to go over 50 employees and incur a penalty for each full-time employee who does not have proper insurance as defined by the government. They are also being buried under thousands of pages of regulations with thousands more to come with which they'll have to comply, and they'll bear the cost of compliance on their own. Or like Case New Holland, a major manufacturer with operations in Pennsylvania, testified at the field hearing last week, they already expect to spend $126 million over the next decade just to comply with this law. And that's $126 million that won't go towards expanding their business or creating new jobs. We're receiving reports almost weekly that show that the true cost of Obamacare is worse than what any of us expected. Higher premiums, more federal health spending, fewer jobs, less access, and people losing the coverage they currently have and like. Not only does the law not achieve its stated goals, the true cost of Obamacare is too high for our states, too high for the federal government, and too high for the private sector. I'd like to thank all of our witnesses for being here today, and I'll yield the remainder of my time to Dr. Burgess.
I thank the Chairman for the recognition. Today we are faced with the question, is the Affordable Care Act affordable? We don't know. We didn't know when this committee passed a health care bill last year called H.R. 3200. Mercifully, that bill died a natural death in the Speaker's office, and H.R. 3590, as everyone knows, was signed into law a year and a week ago. But even today, we don't know about the essential benefits package. We don't know about the cost of setting up the exchanges. All of this remains shrouded behind a veil of obscurity. After the bill became law, our actuary from Center for Medicare and Medicaid Services released his findings to the Congress and estimated the overall national health expenditures would be increased by some $311 billion, a significant difference from the $142 billion in savings that was advertised merely a month before. So I authored last year a resolution of inquiry requesting the transfer of internal health and human services communications related to the date of Mr. Foster's report. The Congressional Budget Office and the Chief Actuary do model different things, and this has been pointed out to me by some of our witnesses this morning, but both are essential components to determining the cost, the true cost of the Affordable Care Act, and really should have been made available to the members of Congress before the vote was taken last year. If the intent of reforming the health care system was indeed to bend the cost curve, then looks like mission accomplished. Unfortunately, we bent it in the wrong direction. Now, I acknowledge that the Congressional Budget Office had an impossible job, and most members of Congress do recognize that, and I guess I would just ask the question, if we rely solely on the Congressional Budget Office, when we know they have an impossible job, if we rely solely on their numbers, are we in fact not facing reality? What if their assumptions are off by just a little bit? The result of maybe 5% of employers dropping coverage and moving employees into the exchanges, what effect does that have on the cost of the subsidies in the exchanges when that kicks in a few years' time? Probably an average of tens of billions of dollars. Now, why was Congress negligent in our responsibility to see the impact that this law would have on the healthcare system, the cost of the healthcare system? The administration knew that it would take Mr. Foster time to complete his model, but did the administration push us to have that vote before we could have access to the actual data? And this is the question that needs to be answered this morning. Thank you, Mr. Chairman. I'll yield back.
Chair thanks, gentlemen, and recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. We're back from another week off in Congress, and it's time for the Republicans to try to repeal, defund, or criticize the health care reform again. It's pretty clear that the Republicans believe that if you just keep saying the same thing over and over again, it'll start to be believed. Just fire up the old talking points, throw in a little righteous indignation, and you're good to go. And that would be just fine if we were all talk radio stars, but we're not. We have a job to do. We're legislators. We're supposed to be trying to turn the economy around and create jobs. But here we are to talk again about the Affordable Care Act, which is just the Republicans' reheated arguments about repeal and replace, except they forgot to replace it with anything to speak of. The Republicans seem to wish that if they just click their heels 3 times, we could return to that magical time in the last decade when they controlled both houses of Congress and the White House, and as they would tell it, business prospered and fiscal responsibility was the name of the game. Except that's not what happened. When President Bush came to office, he inherited a surplus projected to total $5.6 trillion over 10 years, and he managed to swiftly squander that, leaving President Obama a nicely wrapped $1.3 trillion deficit in 2009. Under President Bush's watch, the number of uninsured increased by 6 million nationwide. Small businesses, which make up the majority of the uninsured in America, were hurt especially hard during this time. While 57% of small businesses were able to offer health insurance in 2000, only 46% were able to by the end of the Bush administration. And it would have just gotten worse. By the time President Obama took office, national health expenditures surpassed $2.4 trillion in 2009, more than 3 times as much as it was in 1990. The percentage of income families spent on employer-sponsored health insurance rose from 12 to 22% from 1999 to 2009 during the Bush administration, and those without insurance were even worse off. For many families who had worked hard, saved hard, and planned for the worst, they still couldn't stay in the black if their kid got sick or denied health insurance for life due to a pre-existing condition, or if they themselves got sick with a tough disease and quickly ran through their insurance plan's annual limits. So understanding this, President Obama and the Congress, including this committee, didn't just sit around and whine about the previous 8 years under Bush. They stood up and led. And we're very proud of the health care reform, the economic certainty, insurance reform, and coverage expansions will offer families across the nation. We're glad that small business owners like Rick Poore, who will testify later this morning, are now eligible for tax credits today to cover their employees. And in the future, Rick will be able to leverage the purchasing power of small business owners across the nation through the state exchanges so that more of his money can be invested in his business and more of his energy can be devoted to innovation. I'm very proud that the Affordable Care Act will control health care spending by making important delivery system changes that reward quality, not quantity of care. We're proud that Americans will no longer be held hostage to insurance companies as a result of the reforms in our legislation. And I'll remind you that the Congressional Budget Office has estimated the Affordable Care Act will reduce the deficit by $124 billion by 2019 and further cuts the deficit by $1.2 trillion in the second 10 years. So if the Republicans want to spend another Wednesday morning discussing the true effects of the Affordable Care Act today, I'm game. But I think we really need to get back to work and try to create jobs instead of wasting our time trying to repeal health reform. I mean, it's how many weeks now since you first repealed the act, and of course the Senate rejected it. We've had nothing but hearings for the most part on either repealing the bill, repealing part of the bill, defunding the bill. Now, talking about another hearing talking about the financial aspects of the bill. It just never seems to end. So I would now yield the remaining time to my colleague from California, Representative Capps.
Thank you, Mr. Pallone. To underscore what you have just said, we've been in session for 10 weeks now, and the majority has yet to produce a plan to create jobs or strengthen the economy. Instead, our Republican colleagues are here yet again to live in the past and attack the Affordable Care Act. Many of the claims we are going to hear today about the so-called true cost of the Affordable Care Act are likely to be shocking. But that is not because the Affordable Care Act is dangerous or because it's not working. Instead, it's because these claims are at best gross exaggerations and at worst complete fabrications. Let's be clear. The Affordable Care Act is the largest deficit-reducing bill enacted by Congress in the last decade. It will reduce the deficit by $210 billion over the next 10 years and by $1.2 trillion over the following decade. And it will do so while continuing to help families and small businesses. And as I yield back, the very sections of the bill Republicans are trying to defund are the provisions which will reduce the deficit. I yield back.
Chair thanks the gentlelady and now recognizes the chairman of the full committee, Mr. Upton, for 5 minutes for an opening statement.
Well, thank you, Mr. Chairman. I, too, thank you for holding this hearing. We just did mark the one-year anniversary of the health care bill being signed into law last week. Yet today will be the committee's first chance to fully explore the true fiscal impact that the law will have on our nation's budget and job creation. Last week, the CBO noted that the coverage provisions of PPACA would cost $1.445 trillion for fiscal year 2012 through 21. This is up from a 10-year cost estimate of $938 billion when the bill was signed into law. This is not a change in CBO scoring. Indeed, the CBO estimates for the overlapping years are remarkably consistent. The larger figure simply proves that if you take away some of the gimmicks, mainly paying for only 6 years of benefits in the first decade, that the cost far exceeds $1 trillion and will likely top $2 trillion over a full 10 years. We've also heard about how PPACA imposes a paperwork nightmare on small businesses. The law, as we know, requires a tax filing for every transaction over $600. The House has voted to repeal this massive paperwork cost on American employers. However, our job does not end there. PPACA also includes dozens of new paperwork requirements that force businesses to report to HHS, the Department of Labor, and the IRS. Job creation is our top priority, which is why we cannot ignore the fact that PPACA reduces employment. In recent testimony before the House Budget Committee, Mr. Elmendorf stated that 800,000 jobs will be lost because of the new health care law. We should be creating jobs, not destroying them, which is why many of us believe that we should repeal this job-destroying bill. Many of us believe that we must repeal the uncertainty that it's causing businesses and the hundreds of billions of dollars in new taxes and mountains of paperwork, and I would yield the balance of my time to Dr. Gingrey.
I thank the chairman for yielding. Mr. Chairman, it was just interesting to hear the ranking member of the subcommittee a few minutes ago talk about how the Democrats came to the rescue after 8 years of Republican inaction on health care reform, essentially saying, just don't sit there, do something. Well, I think my colleague, Dr. Burgess, a fellow OBGYN physician, would remember our OBGYN motto, don't just do something, sit there in managing labor and delivery. And the point I'm making is to rush to judgment to do something, just to get something done, oftentimes is a huge mistake. And I think that's the way our side of the aisle feels in regard to PPACA, the Affordable Care Act, because it doesn't accomplish any of the goals that were set out. It's not good for patients. It's not good for consumers. It's certainly not good for corporate America, and it's not good for the taxpayer. So bottom line is this is a bad bill. Not that the idea of reforming health care is a bad thing to do, but certainly the priority of doing it as the number one or number two things in the 111th and 110th Congress, when we had 16 million people out of work in this country and probably 25 million underemployed, an unemployment rate of 10%, deficits he said they inherited a $1.4 trillion deficit. Well, how about the next year when it was $1.6 trillion? Who inherited that? And how about the $5 trillion worth of additional debt that was piled on to the taxpayer by the Democratic majority since they took control in 2007? So I think their priorities are all wrong and backwards in regard to this. And I'm really interested in hearing from our witnesses, the first panel, of course, CBO, Mr. Elmendorf, and our actuary, CMS actuary, Mr. Foster, because we need this information. So if there's any time remaining, I'll just yield that back to Mr. Upton controls the time, I guess.
I yield to Ms. Blackburn.
I want to welcome our witnesses today. And to the witnesses and my colleagues, I would just remind you all, in Tennessee we had an experiment called TennCare. TennCare eventually consumed 35.3% of our state's budget before Governor Bredesen took action to try to get this under control. This was public option health care, and it was the experiment for public option health care. And I would like to hear from our witnesses today if there has ever been any project where you gambled on making all these short-term expenses in order to receive long-term savings, and the savings came. From our research work, you can't find an example. It's one of the dangers we have in Obamacare. I yield back.
Chair, thanks, gentlelady, and now recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you very much, Mr. Chairman. I find this hearing to be sadly ironic. The Republican members of the House have frequently complained about the growth in spending in government health programs. We hear on a daily basis about how Medicare and Medicaid are jeopardizing the financial health of this country, and about how it's time we had an adult conversation about spending. Yes, let's have an adult conversation. Adult conversations start with facts. These are the facts. When President Bush came to office, he inherited a surplus projected to total $5.6 trillion over 10 years. When President Obama came to office, he inherited a deficit in 2009 of $1.3 trillion for that 1 year alone. The deficit widened, I would remind my colleagues on the other side of the aisle, because we went into the deepest recession since the Great Depression, which meant fewer revenues and greater expenditures, widening the deficit more. President Bush did not think national debt was a high priority. Instead, rather than pay it off, he passed a series of reckless tax increases that enriched the wealthy at the expense of everyone else. Those tax cuts, like the Medicare prescription drug bill and 2 wars launched under President Bush, were not paid for. They were charged straight to the national credit card. And that's how you take a $5.6 trillion surplus and turn it into a massive deficit. Healthcare has played a role in this drama. In the future, increasing numbers of baby boomers and stubborn healthcare spending growth will put pressure on our budget without question. But the deficit crisis we find ourselves in is a man-made crisis. In fact, it is a Republican-made crisis. CBO projects that growth in Medicare under the Affordable Care Act will be slowed to historically low rates on a per capita basis to just 2% per year over the next 2 decades, compared to a 4% per capita historically. Projected spending on Medicare would fall well below even projected annual growth in GDP per capita, which CBO pegs at 3.7% over the next 10 years. Medicaid, too, has historically had a slow growth on a per capita basis relative to private health plans. Over the last decade, Medicaid costs grew 4.6% per person per year compared to 7.7% for employer-sponsored premiums. Now, the gentleman on the other side of the aisle said, I didn't know why we went into this reform of health care. Well, things were not great. 50 million people couldn't get health insurance. Health care costs were increasing so rapidly. We needed to do something. The Republicans evidently said, let things go as they're going, and they were going in the wrong direction. The Affordable Care Act has been the largest deficit-reducing bill passed by Congress in the last decade, so it's true to its name, affordable care. So our current deficit crisis right now is not about health care. In addition, the Affordable Care Act covers 32 million Americans. Republicans never offered anything to do that. The health care bill stops insurance practices that would deny care to people who have to look to the private market. It would protect them from being excluded because of previous conditions and other arbitrary insurance practices, which they had to do because they didn't have everybody else in the pool. Well, let's go back to our adult conversation. Republicans keep telling us that we can't afford the reforms to Medicare that the ACA proposed. Now they're telling us that once we repeal the ACA, we need to pass much larger cuts to Medicare and Medicaid in order to pay for tax cuts for the very richest Americans. Majority Leader Eric Cantor said in a speech last week, talking about Social Security, Medicare, and Medicaid, we're going to have to come to grips with the fact that these programs cannot exist if we want America to be what we want America to be. How dare he say these programs cannot exist? This is not what the American people want. The Affordable Care Act is an entitlement reform done responsibly. It's time we stop trying to repeal it and moved on to real work and real legislation. Mr. Chairman, I just think that we hear these complaints from the other side of the aisle. What do they have to offer? If what they have to offer is to cut back on Medicare and Medicaid and Social Security, they'll create jobs because the elderly and the poor are going to have to find work, but they're not going to find them. They're just going to have to do without the care, and we're going to have more uninsured. I yield back my time.
The gentleman's time has expired. Chair thanks the gentleman.
Mr. Chairman, I was supposed to be less time and yield a minute to Mr. Dingell. At some point, could we give him a minute? May I ask unanimous consent that Mr. Dingell be given 1 minute?
Is there any objection? Without objection, the gentleman's recognized for 1 minute.
I thank my good friend. I have an excellent statement. It denounces this hearing. It denounces the purposes of my Republican colleagues. It denounces the fiction that we're going to be hearing this morning from the other side of the aisle. I would urge my colleagues to read it. It will benefit everybody, and I'm sure you will enjoy reading this. And I thank you, and I ask unanimous consent to revise and extend my remarks.
Without objection, so ordered. Chair thanks the gentleman. We have two panels today. Each of the witnesses has prepared an opening statement that will be placed in the record.
All right,
I'll now introduce the first panel of two witnesses. Our first witness is Doug Elmendorf, who is the director of the Congressional Budget Office. Before he came to CBO, Mr. Elmendorf was a senior fellow in the Economic Studies program at the Brookings Institution. Next, we will hear from Rick Foster, who serves as the chief actuary at the Office of the Actuary at the Centers for Medicare and Medicaid Services. Dr. Elmendorf, we ask you to please summarize. You are recognized for 5 minutes for your opening statement at this time.
Thank you, Chairman Pitts, Congressman Pallone, and members of the subcommittee. I appreciate the opportunity to testify today about CBO's analysis of the Patient Protection and Affordable Care Act and last year's Reconciliation Act. Together with our colleagues on the staff of the Joint Committee on Taxation, we provided to the Congress numerous analyses of this act and the legislation leading up to it My written statement summarizes that work. In brief, we estimate that the legislation will increase the number of non-elderly Americans with health insurance by roughly 34 million in 2021. About 95% of legal non-elderly residents will have insurance coverage in that year, compared with a projected share of 82% in the absence of the legislation and about 83% today. The legislation generates this increase through a combination of a mandate for nearly all legal residents to obtain health insurance, the creation of health insurance exchanges operating under certain rules and through which certain people will receive federal subsidies, and a significant expansion of Medicaid. According to our latest estimate, the provisions of the laws related to health insurance coverage will have a net cost to the Treasury from direct spending and revenues of $1.1 trillion during the 2012-2021 decade. That amount is larger than CBO's original estimate of the cost of those provisions during the 2010 to 2019 decade that represented the 10-year budget window when the legislation was originally estimated. That increase almost entirely to the shift in the budget window. As you can see in Figure 2 in front of you, the revisions in any single year are quite small. In addition to the provisions related to insurance coverage, the PACA and the Reconciliation Act also reduced the growth of Medicare's payments for most services, imposed certain taxes on people with relatively high income, and made various other changes to the tax code, Medicare, Medicaid, and other programs. As you can see in Figure 1, those provisions will, on balance, reduce direct spending and increase revenues, providing an offset to the cost of the coverage provisions. According to our latest comprehensive estimate of the legislation, the net effect of all the changes in direct spending and revenues is a reduction in budget deficits of $210 billion over the 2012 to 2021 period. Not surprisingly, observers have raised a number of challenges to our estimates. Let me comment briefly on the three most common areas of concern that I've heard. First, some analysts have asserted that we have misestimated the effects of the changes in law. Those concerns run in different directions. Some analysts believe that the subsidies will be more expensive than we project, while others maintain that the Medicare reforms will save more money than we project. Certainly, projections of the effects of this legislation are quite uncertain, and no one understands that better than the analysts at CBO and JCT. Our estimates depend on myriad projections of economic and technical factors, as well as on assumptions about the behavioral responses of families, businesses, and other levels of government. All of these projections and assumptions represent our objective and impartial judgment based on our detailed understanding of federal programs, careful reading of the research literature, and consultation with outside experts. In addition, our estimates depend on a line-by-line reading of the specific legislative language. Our goal is always to develop estimates that are in the middle of the distribution of possible outcomes, and we believe we have achieved that goal in this case. A second type of critique of our estimates is that budget conventions hide or misrepresent certain effects of the legislation. I'll mention two of the prominent examples that I've heard. As one example, the numbers I've just cited involve changes in direct spending and revenues, because that is what is relevant for pay-as-you-go procedures, and because those changes will occur without any additional legislative action. However, PPACA and the Reconciliation Act will also affect discretionary spending that is subject to future appropriations. We noted many times that we expect the cost to the Department of Health and Human Services and the Internal Revenue Service of implementing the legislation will probably be about $5 to $10 billion each over the next decade. PPACA also includes authorizations for future appropriations. Those referring to specific amounts total about $100 billion over the decade, with most of that funding applied to activities that were being carried out under prior law, such as programs of the Indian Health Service. Another example of concern about budget conventions involves the Hospital Insurance Trust Fund, which covers Medicare Part A. The legislation will improve the cash flow in that trust fund by hundreds of billions of dollars over the next decade. Higher balances in the fund will give the government legal authority to pay Medicare benefits for longer than otherwise. But most of the savings will pay for new programs rather than reduce future budget deficits. and therefore will not enhance the government's economic ability to pay Medicare benefits in future years. We wrote about those issues as the legislation was being considered in the Congress. A third type of critique is that PPACA and the Reconciliation Act will be changed in the future in ways that will make deficits worse. As with all of CBO's cost estimates, the ones for this legislation reflect an assumption that the legislation will be implemented in its current form. We do not attempt to predict the intent of future Congresses that might choose to enact different legislation. At the same time, we emphasize that the budgetary impact of this legislation could be quite different if key provisions were changed, and we highlighted certain provisions that we expect might be difficult to sustain for a long period of time. Thank you.
Chair, thanks. Chair, thanks the gentleman. Recognizes Mr. Foster for 5 minutes for opening statement.
Thank you. Chairman Pitts, Representative Pallone, other distinguished subcommittee members, thank you for inviting me here today to testify about the financial impacts of the Affordable Care Act. The Office of the Actuary at the Centers for Medicare and Medicaid Services provides actuarial, economic, and other technical support and information to policymakers, both in the administration and in Congress. We do so on an independent, objective, and nonpartisan basis, and we have performed this role throughout the last 45 years since the enactment of Medicare and Medicaid. I'm accompanied today by two folks, John Chateau, who is a fellow of the Society of Actuaries, and he's the director of our Medicare and Medicaid Cost Estimates Group, sitting right behind me, and by Leming Kai, who is a PhD in economics and is one of our senior economists. Both are members of our health reform modeling team. I'm very pleased to have the opportunity to appear with Doug Elmendorf. Now, I know you probably saw the press reports of a cage match or a possible fight between us or various humorous things like that, but I'm afraid the reality is far less dramatic. Doug and I and our staffs, we are all public servants, and our goal is just to try to do the best job we can to provide valuable technical information for you all. That's all we're trying to do. I'm not running for president. I suspect you're not either. And if nominated, I know what would happen with either one of us. Now, Doug has already talked about the overall impacts on expenditures and revenues under the Affordable Care Act, so I won't go over that same material. I will mention that we have estimated the impact of the Affordable Care Act on total national health expenditures from all sources, not just federal expenditures, not just for Medicaid or Medicare, but everything. And that increase, Chairman Pitts, you quoted earlier, we estimated a net increase overall of about $311 billion through fiscal year 2019. There are substantial increases, of course, associated with the coverage expansions in the legislation through Medicaid and the exchange private health insurance. There are partially offsetting reductions in national health spending, principally because of the lower Medicare expenditures. And there would also be lower out-of-pocket costs for individuals because so many more of them would have health insurance coverage and for other reasons. I want to say just a couple of words about concerns that I have had and have expressed with one important aspect of the Affordable Coverage Act. And that has to do with the annual payment updates under Medicare for most categories of providers. Specifically, these annual payment updates are based on the increase in a market basket of prices that providers have to pay for wages or rent or energy costs or supplies, you name it, is based on that increase in prices, input prices, minus the overall economy-wide increase in productivity, which is about 1.1% per year. Now, this adjustment, which is permanent, this will happen forever until you all decide maybe it should be changed. But this adjustment will be a strong incentive for providers to economize, to get rid of any inefficiency, waste, et cetera, be as efficient as possible. But I believe it's doubtful that many health providers can improve their own productivity enough to match the level of economy-wide productivity. Now, if they can't, then the consequences are that Medicare provider payment rates would, for most providers, would grow about 1.1% per year less than their input prices or their input costs. And unless they can improve their productivity to match, eventually they would become unable or unwilling to provide services to Medicare beneficiaries. Now, long before that would happen, I think Congress would step in and change the basis to prevent such access or quality problems. But if that happens, that means the Medicare savings we've estimated would be lower. Actual Medicare costs would be higher than any of our estimates. Let me finish by saying that I pledged the Office of the Actuary's continuing assistance to you all and your colleagues and to the administration as you work to continue to determine optimal solutions to the high cost of health care in the U.S. Thank you, and I'd be happy to answer any questions.
Chair, thanks, gentlemen. Thank the panel for their opening statements, and I'll now begin the questioning and recognize myself for 5 minutes for that purpose. Mr. Elmendorf, your testimony states that the health care law will reduce employment by roughly 800,000 by 2012 because PPACA encourages some people to work fewer hours or withdraw from the labor market altogether. You also attribute some of the job reduction to higher marginal tax rates included in PPACA. I would like to explore what other factors were included and excluded when you calculated this number. Does this 800,000 job reduction figure account for employers who will reduce employment in order to avoid the 50-employee threshold that triggers PPACA's employer mandate?
Mr. Chairman, we did not explicitly model that provision. There are a number of factors that we did incorporate in reaching this estimate. We didn't try to quantify every single aspect of the law. We tried to quantify the ones that we thought were most significant.
Does the 800,000 figure account for employers that choose to avoid creating jobs in order to avoid the 50-employee threshold that triggers PPACA's employer mandate?
Again, Mr. Chairman, we did not explicitly model the effects of the 50-employee threshold. We focused on the maybe 10 other aspects of the legislation that we thought would have more significant effects on employment.
Okay. Does the 800,000 figure account for the new employer paperwork requirements in PPACA, such as the 1099 filing provision and the variety of reporting requirements to the Department of Labor and Treasury and HHS included in PPACA that will shift employer resources away from investment towards regulatory compliance?
Mr. Chairman, it's not obvious to me why the 1099 forms would have a significant effect on employment. But no, we did not incorporate any such effect in this estimate.
How about, does the 800,000 figure account for the employer resources that will have to shift toward providing more expensive health coverage as a result of the new mandates and the essential benefits package included in PPACA?
So, Mr. Chairman, in our analysis of the effects of changes in health insurance payments by employers, we recognize that both logic and evidence suggest that changes in particular aspects of compensation to employees tend to be offset by changes in other aspects of their compensation. So one can see in the aggregate data for the United States a rise in health spending by employers over the past several decades, but also a slower rise in cash compensation, and economists think those factors are related. So we think that changes in the extent that employers pay more for health care, and some would pay more under this legislation, some would pay less under this legislation. We've not tried to tote those up. And in any case, we think there would be offsetting changes in the cash compensation that employers would provide.
Mr. Foster, proponents of PPACA argue that U.S. health spending of 16% of GDP is unsustainable and claim that PPACA bends the cost curve. Does PPACA change this dynamic for the better or the worse?
We've estimated this question for the first 10 years And as I mentioned briefly, we estimate that the legislation increases the overall amount of total health spending in the U.S. By roughly 1 percentage point. In terms of the growth rates and what happens in the future, initially the growth rates are higher because we're spending more, but there are certain factors that would tend to reduce the growth rates in the longer term. A good example is the productivity adjustments for Medicare payment updates. The real question is, how long can that work? They will help slow Medicare spending growth, but they may not be viable indefinitely.
Can you explain how a strict application of modified gross adjustment could greatly expand Medicaid eligibility under PPACA and increase the cost to both the federal government and states?
Yes, sir. In the legislation, to achieve consistency between the definition of eligibility for Medicaid and the definition of eligibility for exchange subsidies, Congress decided to use modified adjusted gross income as the basis for determining income. Now, prior to this point, for Medicaid, almost all states, or perhaps all, have included Social Security benefits in their definition of income for purposes of determining eligibility. With modified adjusted gross income, in contrast, for most people, only a small portion, if any, of their Social Security benefits would be included in that definition of income. So if you consider Social Security early retirees under 65 who are potentially eligible for the Medicaid expansion, and you then don't count $10,000 or $20,000 a year of of Social Security benefits in their income, many of them can potentially qualify for Medicaid if you use that strict definition of modified adjusted gross income.
Chair, thanks, gentlemen. And now recognize the ranking member, Mr. Pallone, for 5 minutes for questioning.
Thank you, Mr. Chairman. I wanted to address my questions to Mr. Elmendorf. Mr. Elmendorf, I'm sure you could tell from my opening statement that I'm very frustrated because I feel that, you come here and you did the best, and we were using your numbers because we're supposed to in deciding, the cost of a legislation. And, of course, if we didn't go by CBO, or if CBO said that things cost too much, then they would criticize us. And then when we finally came up with a bill that actually resulted in some significant deficit, savings, and they said, well, those numbers aren't actually good. So, the whole purpose of this hearing is essentially to challenge you and say, essentially that we don't agree with what you're doing. But, of course, if we hadn't followed it, then we'd be criticized because we didn't follow you. So I just wanted to go through some of the things because tomorrow I understand we're going to have a markup on some bills that we had a hearing on just before the break. And Representative Bachmann and members of this committee are claiming that there's about $105 billion in hidden spending that was snuck into the bill without you or the American people knowing about it. And the hearing was, of course, on this hidden mandatory spending, and that's what the markup will be about tomorrow. So let me just go through and find out whether any of this really was hidden from you. First of all, we considered a bill that would repeal funding for Section 1311, the Health Insurance Exchange Planning and Establishment Grants. Did you know about that funding stream?
Yes, Congressman.
Okay, so it wasn't hidden. What about Section 4002, the Prevention and Public Health Fund? Did you know about that?
Yes, Congressman.
So that wasn't hidden either. And what about funding for school-based health centers? Did you know about that?
Yes, Congressman.
So it seems that we couldn't slip much past you, try as the Republicans think we might. It's also true that I guess it was Congressman Jerry Lewis, Appropriations Committee. He said that there's about $100 billion in new discretionary funding in the bill. That, of course, was hidden or, that we were trying to hide. But I see you mention in your testimony that $85 billion of that is what actually was just reauthorization of pre-existing programs like the Indian Health Service or the community health centers. I was a sponsor of the Indian Health Care Improvement Act that was included in the bill. So $85 billion of this 100 in discretionary was actually just reauthorization of pre-existing programs like the Indian Health Service. Is that correct?
Yes, that's right, Congressman.
All right. I mean, reauthorization of existing programs is, of course, a standard practice in this committee, both under the Democrats and the Republicans. Now, I want to go back over your deficit numbers. CBO and JCT analyzed all of the revenue and spending changes in the health reform law and estimated that it would reduce the deficit by $210 billion over 10 years and by about half of 1% of GDP, or $1.2 trillion in the following decade. Recently, in your routine updating of your baseline projections, you made some changes to your projections of spending in Medicare, Medicaid, and health insurance exchanges. That's correct?
Yes, that's right.
Did you update your cost estimate for the Affordable Care Act?
No, we did not do a comprehensive reestimate of the effects of the Act.
Did you increase your cost estimate for the Affordable Care Act by $500 billion, which I think was suggested in a press release by Chairman Upton?
So, again, Congressman, the last comprehensive estimate we've done for the Act was part of our February estimate of the effects of repealing the Act as encompassed in H.R. 2.
So you didn't increase your cost estimate by $500 billion?
Again, since what we released in February, we've made no new estimates of the comprehensive effects of the legislation.
Do you have any expectation that a new cost estimate would continue to show that the Affordable Care Act reduces the deficit?
So I can't say anything too firmly, having not done the estimate, but I will say that I think it would, given the magnitude of the deficit reduction that we projected based on our February estimate of the effects of repeal, I would be surprised if a new estimate that we did today showed a different sign of the effect on the deficit, although, of course, the precise number would be somewhat different, presumably.
Okay. I mean, I'm not trying to, be too critical of Chairman Upton. I like him, but, he put out this press release last week. He said that with that $500 billion, and I think it's somewhat misleading, and I guess the Washington Post said it was wildly inflated and earned a 3 Pinocchios rating from the Washington Post fact checker column, whatever. My only point is that nothing has really changed here, and I think that the effort on the part of the Republicans to basically discredit you is baseless. Thank you, Mr. Chairman.
Gentleman's time's expired. Chair recognizes the Vice Chairman of the committee, gentleman from Texas, Dr. Burgess, for 5 minutes for questioning.
I thank the Chairman for the recognition. Mr. Elmendorf, of course, you did appear before this committee in the run-up to the passage of H.R. 3200, but you might not recognize it because when you were in that day, the television cameras weren't on, the lights were off, no recorder was at the end of the table, no one was in the audience section. It was obviously an unofficial briefing that you had with, at the time, what was, I recall, described as a back-of-the-envelope calculation. We never had a formal hearing on the Congressional Budget Office's opinion on the passage of H.R. 3200, and we certainly never had any sort of hearing on the budgetary effects of H.R. 3590, because at the time you were here testifying before us, H.R. 3590 was a bill that had been passed by the House of Representatives that dealt with housing issues and not with health care issues. Is that correct?
Yes, I have testified to this committee, but it was early in 2009, before the legislative action that you're describing, Congressman.
Well, you were called in for a briefing, as I recall, and again, there was no recorder, no testimony was taken down, the lights were off, the cameras were off. It was kind of a closed-door, cloak-and-dagger type of hearing, or briefing, as I recall.
I'm confident I did not come to a cloak-and-dagger affair, Congressman. I don't remember the precise circumstances, but I think you're correct.
I recall them vividly. That's why I'm reminding you of them. Well, let me just ask you a question about the funding that's in the bill. And this is just for me. How do you are required to interpret the cost of things under existing law? So under existing law, in the Patient Protection Affordable Care Act, Subtitle D, Patient-Centered Outcomes Research, establishing comparative effective clinical effectiveness research, in the section under funding of comparative effective clinical effectiveness research for fiscal year 2010 and each subsequent fiscal year, amounts in the Patient-Centered Outcomes Research Trust Fund shall be available without further appropriation to the Institute to carry out this section. How do you quantify that?
So I'm told, I'm sorry, I wasn't sure myself, Congressman. I'm told there were specified amounts.
Yeah, that's the problem. We aren't either. But go ahead.
I'm told that in the legislation there are specified amounts made available to the Patient-Centered Outcomes Research Institute.
Well, for fiscal year 2010 and each subsequent fiscal year, and there's no limit put on that, so I've got to assume that's until the second coming, amounts in the Patient-Centered Outcomes Research Trust Fund under Section 9511 of the Internal Revenue Code shall be available without further appropriation to the Institute to carry out this section. Without further appropriation. Now, Chairman Pallone, or Ranking Member Pallone, talks about how we reauthorized several provisions of existing law in the Affordable Care Act. Fair enough, but this wasn't an existing position, an existing provision. This did not go through authorization through this committee. It is never going to be reauthorized by this committee. No oversight of this funding is going to occur by this committee. And these funds, we don't even know the top dollar figure, are appropriated, it looks to me like in perpetuity. Is that a fair reading of this statute?
So I think it's important for me to distinguish between mandatory funding and authorization for future discretionary appropriations.
Yeah, and in fact, I don't know that I have time to get into that.
Our estimate, including whatever...
These provisions should be authorized. We are an authorizing committee. Ranking Member Pallone pointed that out. That's what we do. We authorize these programs. We subsequently, in future years, reauthorize them to ensure that they're working properly, at least if we're performing up to standards the American people should be holding us to. But in this instance, we don't get a chance. So the anxiety that a lot of people have is there's funding like this strewn throughout the language of 3590, and it is going to be very, very difficult for future members of Congress to get a hold of these funding streams and understand, are they performing as they are supposed to? The language makes it difficult for you to tell us really how much money we've obligated the taxpayer to spend on this, whether it's mandatory or discretionary. They don't care. Honestly, they don't care. They want to know how many dollars they're spending and whether those dollars are being invested wisely, if they're getting an appropriate return on investment. How do we advise them? How do you advise them?
All I can say, Congressman, is that the mandatory funding is included in this page after page of our cost estimate, row by row. And if there are specific questions about individual rows, then I hope that you and your colleagues would come and ask us.
I have a specific question about a specific section of the law that was signed into law a year and a week ago, and I would appreciate it if you, I see my time's up, but if you could get back to us with that estimate.
We will do that, Congressman.
The gentleman's time has expired. The Chair recognizes the ranking member of the committee, Mr. Waxman, for 5 minutes for questions.
Mr. Chairman, last week I mentioned in my opening statement, Eric Cantor, the majority leader, gave a speech at the Hoover Institution where he talked about Social Security, Medicare, and Medicaid. And he said, quote, "We're going to have to come to grips with the fact that these programs cannot exist if we want America to be what we want America to be," end quote. Well, I can't come to grips with that statement because it would be a back to the future to a time when seniors and people with disabilities lived in poverty without financial and health security. Dr. Elmendorf, what was the approximate cost of extending the Bush tax cuts in the legislation that was passed last December?
I believe the legislation passed last December had, I'm not sure I know the answer to that question. Legislation passed last tax cut legislation?
The tax cut bill.
I'm sorry. I mean,
Well, I understand.
I don't know it offhand.
Well, I understand it's around $700 billion.
That sounds in the right ballpark to me, Congressman.
And now focusing just on the upper income tax cuts and the estate tax, I'd like you, if you don't have it off the top of your head, to give us an estimate of what it would cost to just extend those for another 10 years.
I can provide that to you later, Congressman.
I believe that the OMB budget lists the cost of extending those tax cuts along with the interest cost as almost $1 trillion, but I'd like you to submit it for the record. That's a huge number, and that's just from the tax cuts for the wealthiest Americans alone. So you take $1 trillion, and then we look at the Affordable Care Act. It has the opposite effect of actually reducing the deficit. Isn't that correct?
Yes, Congressman, by our estimates, it does.
They say that the government is to choose, and we know what Republicans choose. They choose to cut Medicare, Medicaid, and health insurance for middle-income American families to pay for tax cuts for the rich. Dr. Elmendorf, your re-estimate of the President's budget projects some relatively modest changes in projected spending for Medicare and Medicaid and health insurance exchange tax credits. According to your letter to Senator Inouye, in Table 6, mandatory outlays on tax credits are projected to be about $54 billion higher over the next 10 years, while spending on Medicare and Medicaid is projected to be about $339 billion lower, for a reduction in direct spending of $277 billion from these health programs. Is that correct?
It sounds right to me, Congressman. I don't have the letter in front of me.
So projections for spending on health programs are down relative to your prior baseline. You also note in your testimony that spending growth in Medicare is projected to be very low on a per capita basis over the budget window. Is that correct? What is your estimated growth rate?
We did reduce slightly the growth rate of spending by the federal government for Medicare and for Medicaid over the 10-year budget window. I don't have the actual growth rates at hand. They are still, of course, substantial growth rates.
As I understand it, 2% per capita compared to 4% historically, but we'd like to get you to submit that for the record. Mr. Foster, do you agree that cost growth in Medicare is very restrained in the next 10 years or so?
Yes, sir, I do. As I've cautioned, it's not clear that all of the provisions will be viable indefinitely.
So we all agree that Medicare cost growth has been brought to a very low level, so low that in CBO's baseline, the triggers for the Independent Payment Advisory Board are not tripped anymore. Isn't that correct, Dr. Elmendorf?
That's right, Congressman.
Mr. Foster, considering these low growth rates in per capita spending, would you characterize the growing costs of Medicare over the next 10 years as primarily driven by increasing population or by increasing spending per person?
There are still factors of each. I would consider them of comparable order of magnitude. We have the baby boom generation moving into Medicare these days, of course, with people turning 65. So the enrollment is growing about 3% per year. And the cost per person for Medicare is also growing in the rough vicinity of 3% per year, which is much lower than average or normal because of the Affordable Care Act provisions.
Okay. And the Medicaid spending growth that we've seen recently has been primarily driven by increased enrollment due to the recession. Is that an accurate statement?
In recent years, that's basically correct.
So, in effect, Medicaid is fulfilling its essential safety net function. Once the economy recovers, Medicaid costs will go down again because fewer people will need the help. Is that a correct statement?
We would expect that, yes, sir.
Thank you. Thank you, Mr. Chairman.
Chair, the gentleman's time's expired. Chair recognizes the gentleman from Illinois, Mr. Shimkus, for 5 minutes for questioning.
Thank you, Mr. Chairman. It's just curious that the extension of the Bush tax cuts occurred under a Democrat-controlled House, a Democrat-controlled Senate, and signed by a Democrat president. Just for the record, the extension of the Bush tax cuts was passed by a Democratic House, a Democrat Senate, and signed by a Democrat president. I don't know how many years you guys want to run against George Bush, but it obviously gets a little old. You must have, you might find new targets. It's good to see you all here. I became ranking member of the Health Subcommittee after the passage of the law, and I think we asked numerous times for you all to come in open hearing to discuss the budgetary aspects, to be denied every time. And I would agree with my colleague, Mr. Burgess, that, Mr. Elmendorf, you came, but you didn't come with the press available, with people in the galleries with the TV cameras on, without any open, transparent system for us to talk to the American public about the cost of this bill. So we are glad to see you, and I know it's being bean counters that's puts you crossways with both sides as we try to drive our issue. But 2 or 3 weeks ago, we had Secretary Sebelius here, and she admitted on tape in the transcript that the law really double counts Medicare savings. she admitted that, in fact, her final word was both. The Medicare savings that's attributed to extending the solvency of the Medicare Trust Fund is also the same dollars that's used to pay for the health care law, which I would agree with her. And that's been part of the actuary thing. We understand that you have to score what we give you. Obviously, 6 years of benefits, 10 years of taxes. You know, we know that that you have to score what's given. But in some of the testimony, especially on, and this is directed to Mr. Foster, if you back out the Medicare cuts in the bill, what would be the total increase in national health expenditures?
I'm sorry, if you
back out the Medicare cut. I don't know if we've ever cut Medicare in the history of this government.
Yes, if you left out or don't consider for the moment the Medicare savings provisions, then the expansion of coverage for Medicaid.
Well, you say Medicare savings, we say Medicare cuts. Same terminology, right?
It's a reduction in expenditures.
Right.
Call them whatever you like.
Okay, I'll call them cuts, you can call them savings. But there are cuts to what we're all paying for Medicare right now.
Anyway, back to your original question, the expansions of coverage through Medicaid and the federal subsidies for the exchange coverage would increase total national health expenditures by something in the range of 3.5%. And then the savings that you get, or the cuts if you prefer, from the Medicare provisions reduce it.
So my issue is we're triple counting. I mean, 2 weeks ago we got the Secretary to say we double counted. My issue now is that we're really triple counting because we're assuming we're going to cut $500 billion from Medicare that we're not going to do. So if we're not going to do that, we attribute that savings to extending the solvency of the Medicare Trust Fund, which we're not going to do. And we're not going to have the $500 billion to pay for the expansion of the health care law. So the Secretary was right when she said she double counted that. But if we don't do the Medicare cuts, we are triple counting the same $500 billion.
So, Congressman, to be clear, when we give you a cost estimate, it counts each and every provision of a law once and only once. It's certainly the case that if those Medicare cuts or savings do not ultimately come to pass, then the deficit reduction effect of PPACA plus whatever future legislation took back those cuts, that combination of law would not have the same effect on reducing budget deficits that we estimate PPACA to have by itself.
And that's our concern. We appreciate you being here, and I yield back my time.
Mr. Chairman, I'm sorry, Mr. Chairman.
Chair, thanks, gentlemen.
Mr. Chairman, I'm sorry.
Who seeks recognition?
I realize it's not my turn, but I actually have a better answer to Congressman Burgess's
Go ahead.
question, and I see that he is still here. Congressman, Section 6301 of PPACA specifies amounts to be transferred to the Patient-Centered Outcome Research Institute Trust Fund, some from a tax on health insurance premiums, and the amount that we estimate for that was estimated by our colleagues at the staff of the Joint Committee on Taxation based on the specified tax rate in the law. It also specifies transfers from Medicare and amounts that I'm told are specified in dollar terms, and then further amounts from the general fund that are specified.
And the total dollar figure then is?
And the total dollar figure, actually, I don't have that offhand, but it is in our table, and we can provide that to you.
All right, Chair, thanks, gentlemen. Now recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions. Mr. Gonzalez.
Thank you very much, Mr. Chairman. And
gentleman's time has expired. Chair recognizes the gentleman from Louisiana, Dr. Cassidy, for 5 minutes.
Just a quick comment. Medicare also has potentially 10 to 20% of its receipts going out in fraud, so maybe there's something to be said for overhead. Mr. Elmendorf, Mr. Foster, I'm sorry. You mentioned how there may be different ways. Okay, so Dr. Gingrey showed how if we hit this cliff, Medicare and Medicaid payments to physicians and hospitals will decrease dramatically relative to private insurance. And you mentioned that there are different ways that they can compensate for that. Now, I have an article here from Milliman from 2008, which speaks about the hydraulic effect and how in the Milliman article, this is 2008, they estimate that, let's see, significant discounts in Medicaid cause an hydraulic effect, driving up the cost of private insurance, and that it's possible that there would be 15% lower private health insurance cost were it not for Medicaid paying below the provider's actual cost of doing business. Now, it seems as if, knowing that there's a lot of things possible, but it seems most likely that this hydraulic effect will be exacerbated by this kind of cliff that we see with Medicaid and Medicare. Will you accept that?
Yes, that is one reaction we would probably anticipate.
So it's a probable. It's not just kind of maybe out there, but it's a probable. Yeah, I think history would say that's true.
Congressman, can I just add, there are some conflicting forces, though, in this law. So there are reductions in Medicare payment rates. There are also some people who today are, or otherwise, without the law, would be uninsured, who would then be having health insurance.
I will say that just reclaiming my time, Dr. Elmendorf, only because I have limited time, I think the experience in Massachusetts says that broadening access does not control cost. I think that argument has been effectively diminished. But if I can go back to Mr. Foster, not to be rude, but I just have limited time. Mr. Foster, the next thing to say is we know that in times past, and you may have even written this to the effect, that when there is a cliff in SGR, Congress will almost always, in fact, as always, increase that back up. Now, I guess my question for you is I think you do behavioral modifications. You look at a piece of legislation and you can see, wow, sure, this is the parameters given to us, but the contortions given to us do not reflect reality. There should be a codicil, if you will. There should be some addendum that says, you know, using behavioral health, we would discount the effective savings. It seems like you should have used that same methodology as regards this cliff that's going to affect Medicare and the resulting hydraulic effect upon private insurance rates, driving them up 15, maybe 25%. Any comments upon that?
Well, it's actually an excellent point in terms of anticipating what kinds of reactions might happen. We do this where we have a good basis for it and where it affects, for example, the financial status of Medicare or estimating Medicare or Medicaid costs. We don't do it in every case. For example, if there is cost shifting by hospitals or other providers because their Medicare or Medicaid payments are inadequate and they should cost shift to private health insurance.
Driving up the cost for the privately insured. What we're really saying, cost shifting, is driving up the cost. This bill, through its cost shifting mechanism, drives up the cost for the privately insured. Okay, continue.
Yes, and there's some disagreement about to what extent that happens. It's hard to measure.
But going back to my point, wouldn't it have been wise for you to discount the savings, given in mind that the behavioral aspect of Congress is to hold providers harmless on the SGR, as one example?
Well, it depends on what you're measuring, sir. If you're measuring federal expenditures and Medicare saves money but private health insurance gets more expensive, that may not affect federal expenditures.
Then that's a good point, because really you're only looking at federal spending. You don't, in a sense, you're by law required not to consider the fact that we're driving up costs for privately insured.
Well, we also look at total national health expenditure.
I saw that, and that rises. So even though the federal supposedly saves, the fact that there's national health expenditures that rise mean that somebody's eating it, and it's probably the states and the privately insured. I think I'm getting from you that you could have done behavioral intervention, but for whatever reason, your methodology, you chose not to do so.
Not in this particular instance that you've written.
Then let me go to the next point. Everybody's talking about, clearly, press reports said that the reason that this was offloaded upon the states is that it saved the federal government money, but clearly it's going to cost the states a heck of a lot of money. And so I have here a Lewin report, the impact of expenditures. Mr. Waxman, whom I have great respect for, spoken about adult conversation. According to this Lewin report, under this Obamacare bill, his state is going to have increased Medicaid expenditures of $4.8 billion over a 5-year period. Louisiana is going to be $1.5 billion. Texas is over $4 billion as well. So is it well to concede that although federal expenditures are going down, in the case of California, it'll be $4.8 billion higher, Texas $4 billion, Louisiana $1.5 billion higher. We've just cost shifted from the feds to the states?
Most of what's in the bill goes the other way around. There are many provisions that reduce the state share of costs and increase the federal share. Overall, the state cost is not great. I've got specific estimates that we can provide for the record.
So you would dispute the Lewin report?
If I understood what they were saying correctly, I'd want to look at it carefully.
Okay. I'll submit that to the record once I get a hard
Gentleman's time's expired. Chair recognizes the gentleman from Ohio, Mr. Latta, for 5 minutes for questions.
Well, thank you, Mr. Chairman. And gentlemen, thanks very much for your indulgence this morning. Really appreciate you being here. And Mr. Elmendorf, it's good to see you again from my time on the Budget Committee. I was always glad to see you come before the committee and hear your input. You know, I think maybe everybody's been talking to Mr. Foster, so maybe I can talk to you for a couple of minutes here. Yeah, you know, I always, even when I was on the Budget Committee, I always enjoyed reading your statements when you came before the committee. And also, you know, one of the things that we've been talking about this morning, really about physician services, et cetera, talking on page 9 under the heading, Uncertainty Surrounding the Estimates. And again, as from my days on the Budget Committee, I understand that, you know, what you're given is a snapshot. We're looking at a snapshot at that time of the information that you're given to make an estimate on. But, you know, I found it interesting in your statement, just a few things if you could comment on. In the one paragraph you say, in fact, CBO's cost estimate for the legislation noted that it will put into effect a number of policies that might be difficult to sustain over a long period of time. And then you go on to state that it is unclear whether such a reduction can be achieved through greater efficiencies in the delivery of health care or will instead reduce access to care or the quality of care relative to the situation under prior law. And, you know, we heard Mr. Foster talking a little bit earlier in regards to, you know, the economizing, the efficiencies that would have to be done. It's kind of interesting because you're both kind of going the same way. First, under what we call the doc fix, how much was the doc fix before the law went into effect? Do you remember what that number was for the 10-year period?
How much it would have cost over the 10-year period?
Right.
So I think the estimate was about $250 billion as of a year or so ago. I'm not exactly sure.
Okay. And did the health care law look at the doc fix at all?
Health care law did not adjust payment to physicians and Medicare.
Thank you. And again, my next question is, because also following up, you know, we have some our doctors that are on the committee. But when we're talking about, what worries me is when we're talking about the achieved through greater efficiencies or, and I'd like to ask this, reduce access to care or the quality of care. Could you define those two, reducing the access to care or the quality of care that you'd be looking at when you made that statement?
Well, so access to care refers to issues we've discussed here about in Medicaid, which pays significantly less to physicians than Medicare does today, and it varies across states, but on average, it is harder for Medicaid patients to find physicians who will treat them than it is for patients in Medicare or patients with private insurance. And so one of the measures of access is whether people can find doctors to treat them. Quality is a harder thing to measure in medical care, and part of the legislation that we're discussing, in fact, is an effort to increase the dissemination of quality measures and to develop new quality measures. That's a harder thing to look up, but I think those are the sorts of concerns that we've spoken about and that the Office of the Actuary has spoken about as well.
And again, going back, you know, again, knowing, understanding that you're looking at a snapshot of what's being given you, the information that's given to you at that very moment in time to make your analysis on. Was anything ever talked about during that time about reducing that care or that quality of care and what that would do to the system at that time, or to the people that would have to try to get the care?
So a sentence much like this one has appeared in a succession of our cost estimates, beginning at the point where this feature was a prominent part of the legislation that we were providing analysis of. Don't know what consideration these issues were given. I want to just emphasize one point, Congressman. You said several times we were given certain things. I want to be clear. What we were given is a piece of legislation. What we bring to that is our experience and the evidence that analysts have developed.
Well, that's what I mean. You're giving us. We're looking at a snapshot of what's given to you. That you're not going out and getting that information on. You know that you're you're told what you're supposed to look at. Let me ask this real quick, because time's running out here. In the second to the last sentence, it says, so that the shares of income that enrollees that have to pay will increase more rapidly at this point. How much does that increase, do you think? Any idea on that?
It depends on how the economy unfolds. The word, so it's, in fact, the word in the sentence of likely that exchange subsidies will grow more slowly is because we don't know what the economic outcome will be. But I can't quantify the exact change offhand in our baseline estimates, but we can look those up for you, Congressman.
Well, thank you very much. I appreciate your testimony. I yield back, Mr. Chairman.
Gentleman's time expired. Chair recognizes the gentleman from Kentucky, Mr. Guthrie, for 5 minutes.
Thank you, Mr. Chairman. First, I want to comment on the small business tax credits. My understanding, they're only for 2 years. So, and it's only for employees of 25 or less. So if you are a small business with 25 or less, you can be subsidized or with a tax credit for 2 years, and that tax credit goes away. Therefore, you're going to choose either to continue expensive health insurance, which is going to be driven higher by the spill, or drop it. The second of all, if you're a small business, which I consider a small business with 51 employees, I got a lot of them in my district, you have no tax credit and mandated to provide health insurance. Or you choose to put people into the exchange and make that other part. And I don't know if y'all look at that type of behavior when you do that, but I want to go with the question. You sent Mr. Lewis, Mr. Elmendorf, Mr. Lewis, our former ranking member, a letter saying about the appropriations process, appropriations part of it, saying that there was a list of new activities for which PPACA includes only a broad authorization for appropriations of such sums as necessary. And for those activities, the lack of guidance made it difficult for you to come up with a score or necessary amounts. You couldn't bring that forward. The second point, though, is there was one that in Section 1311A1 where the Secretary, and I'll just read it, it's an amount necessary to enable the Secretary to make awards for state-based exchanges. These awards can be used to facilitate enrollment in the exchange. And you estimated that at $2 billion. I think that's the number.
Yes.
And then the Kaiser Health News reported that a member of the administration, Donald Berwick, the Administrator of Federal Centers for Medicaid and Medicaid Services, was talking with the states. The states were talking about the pressure for Medicaid. And he said to them, it was reported in Kaiser Health News, he was sensitive to that situation, but his solutions, however, were to point states to funding that he said is already available to them, such as subsidies to establish insurance exchanges. And I would have to guess that if that's what the administration thinks should happen to help states through their budget crisis with Medicaid, that's going to be far more than $2 billion. So my question is, what assumption did you make with and the Secretary said this in a meeting on March the 3rd, I think it was, 3rd, that she has complete, there's no limits on how much she can spend in this provision. There's no limit. She said that. And she has no need for additional congressional authority to spend it. Obviously, a member of the administration says you can spend it to help states plug their Medicaid budget hole. So what assumptions did you use to get to $2 billion?
So we estimate that outlays for grants in this under the section would be $2.1 billion over the 2011 to 2015 period, at which point the program ceases. Those estimates are based on the cost of implementing other programs in the government that we believe are similar in their structure, not in the precise substantive purpose, of course. And that's the way we do estimates in general of the cost of implementing various programs, is to try to look for analogies in other things the government has been doing. And we, so far, CMS has announced awards of $49 million for planning grants. We think that there'll be, as I said, about $2 billion spent over the 5 years in total.
But if the Administrator of Medicaid Services is correct and it's available, he said he points to solutions to point to states to funding that he said is already available to them, such as subsidies to established health insurance exchanges. So if those subsidies are used in a way that helps the state, because you could facilitate enrollment by granting more money for Medicaid to get more people to enroll in the health care exchanges. That would follow under the law. I know you can't model that behavior.
So under this section, I believe, limits the grants to activities related to establishing insurance exchanges. And so I don't think that changes in enrollment amount are activities related to establishing an exchange. Certainly the case that this $2.1 billion number might be too low. It might also be too high in our judgment. We think we've tried to put it in the middle of the distribution of possible outcomes.
I understand what you had to do. You had to take what similar model. I understand your modeling requirements, but my point that I'm making, the people in administration are taking a far broader turn than that. I know you have to use as you look at examples, but I think facilitate enrollment in the exchanges is a broad term, and obviously people in the administration seem to think that way. At least somebody at the very, somebody that should require Senate confirmation made that comment. So, but I would like to yield the last 30 seconds to my friend from Louisiana.
Mr. Foster, I think that the issue is that in the aggregate there's less spending in states, but because New York is such a high-cost state, all the savings, frankly, come from New York and a few other states like that, Massachusetts. But if you take the people who are who are not eligible at less than 138% of federal poverty and you move them up, that's why California, which has a lot of poverty, even though it has a high mean per capita income, again, it's going to be $4.8 billion from 2014 to 2019 in increased Medicaid expenditures. Again, does that seem reasonable to you that maybe New York is offsetting everybody else?
I'm sure there are significant state-by-state variations in the net impact. We've only estimated the overall national, not the individual states.
Okay. Thank you.
All right. Thanks. Gentlemen, recognize gentleman from Vice Chairman for one follow-up.
Thank you, Mr. Chairman. I appreciate the courtesy. Mr. Foster, in your prepared testimony, you say you're here today in your role as an independent technical advisor to Congress. Perhaps offline you can expound for us what triggers that role as different from the chief actuary to the Center for Medicare and Medicaid Services. And the reason I feel this is important, and the reason I asked for the resolution of inquiry last year is what triggers that role. Now, we were in a sort of a rush to pass a year ago the Patient Protection Affordable Care Act, and I cannot escape the feeling that we were asked to vote on that bill before we had all of the data. So really my question to you is very simple. Do you feel we had the full picture March 23rd, 2010, or March 21st of 2010 when this vote was called on the floor of the House? In your role as an independent technical advisor to Congress, not as a chief actuary for Center for Medicare and Medicaid Services.
Sure. In either role, I do the same thing, which is give you an honest answer to an honest question. What happened was the legislation was complicated. It took our team working on this some period of time, from the time we got the legislation until we could produce an estimate we were comfortable with. Now,
were you able to convey to the Speaker of the House that information, that you did not have a figure that you were comfortable with prior to Congress taking a vote on something of this magnitude?
The Speaker of the House did not ask us. Various members of the House and Senate did ask us from time to time, could we have something, could we have it by prior to the vote that was scheduled. In, I think, all instances, we are not able to produce our estimates to complete them before the vote actually occurred. Now, our goal was to do that, but it was too hard within the time available.
But it's not like the train was going to run off the railroad bridge if the vote didn't happen on March 21st. We could have voted on April 21st, could we have not, and had time for your independent technical advice?
If the vote were delayed, clearly, yes. That.
In retrospect, you think Congress would have benefited from having your opinion on the cost of this legislation?
Oh, on a good day, I think our advice is useful.
Well, all right. The ranking member has a follow-up question. Mr. Waxman.
Mr. Foster, no one delayed you from getting your estimate. You just weren't able to get the estimate in the time you had hoped. Is that correct?
Well, that's correct. I mean, for CBO and Doug, you got the legislation early on because nobody wanted to finalize it without knowing the effects. We never got the legislation until it was announced publicly. We could only start at that point to do our work, so we were constantly behind you.
And did you ever give a final estimate of the actual bill that's passed the Congress?
Yes, sir, on April 22nd.
Okay. Were you prevented from giving the Congress all the information it should have had on when the Medicare prescription drug bill was voted on in the House?
There were 2 or 3 instances where we gave the information to the head of the agency who did not pass it on. That was investigated by OIG and GAO. The legal opinions that came out of that indicated, in my opinion, that we, in fact, have the right to serve independently on your behalf. And ever since those legal opinions came out, we have delivered responses to your requests directly. And
but at the time we were voting on the prescription drug bill, you didn't have that opinion that would allow you to communicate with us directly, and therefore you did not communicate with us directly in the Congress.
Not in every case. We tried our best, but it was a difficult circumstance.
Well, the distinction I would make for the benefit of my colleague is that in that instance, the Republican administration stopped the information or tried to prevent the information from coming to Congress. No one in the Congress or the administration tried to stop you from communicating your best judgments on the estimates for this health care bill. Is that a correct statement?
That's correct.
Thank you.
All right. The chair thanks the gentleman, and that concludes the round of questioning for the first panel. Members who have other questions will submit them in writing. We ask the witnesses to respond promptly to those. The chair thanks the first panel, and now...
Mr. Chairman, before we go to the second panel, may I ask a parliamentary inquiry?
Yes, the gentleman stated his parliamentary inquiry.
We have, I'm not objecting to this witness testifying, but we have Mr. Holtz-Eakin testifying. He's associated with American Action Forum. We don't know where they get their funding. That's not disclosed. We don't know if they get any government grants because their funding has not been disclosed. There is a rule that says that we'll have truth in testimony, and when a witness testifies, they have to disclose some information about funding. Mr. Holtz-Eakin has maintained that he is testifying as an individual and not representing his group. So my inquiry to you is, what is the standard that we have? When can we have a witness come before us and be able to just say they're going to testify as an individual and not have to make the disclosure that they would otherwise be required to make? What standard should we have to consider for the future?
Gentlemen will
suspend. If the chair would want to get further inquiry and put on the record, that would be helpful to us. I'm not asking for an immediate answer, but it seems to me we need to have a standard that we all understand, because some witnesses are required to give disclosures, and evidently Mr. Holtz-Eakin is not required to give a disclosure, so because he's testifying as an individual. When do we let people testify as an individual and therefore not make disclosures, and what circumstances do we require those disclosures? I just want us to know the policy. You don't have to do it off the top of your hat, but I think we ought to make it clear.
The chair will be happy to respond after talking to counsel and make it a part of the record.
Thank you very much.
Can I ask a question?
Chair, thanks, gentlemen. I'll ask the second panel to please take their seats, and I'll introduce them at this time. We will now hear from the second panel with their opening statements. We'll hear first from Douglas Holtz-Eakin. Mr. Holtz-Eakin is an economist by training. He has studied the effects of numerous health care policy proposals in the past and is a former director of the Congressional Budget Office. Next, we will hear from Mr. David Cutler, the Otto Eckstein Professor of Applied Economics at Harvard University. We will then hear from a trio of business owners and hear their thoughts on the impact of the new law. First will be Philip Kennedy, who is the president of Comanche Lumber Company, a small business located in Oklahoma. Next, we will hear from Rick Poor, the president of Design Wear Velocity, a T-shirt design company located in Nebraska. Finally, we will hear from Larry Schuler, the president of Shoes Hospitality Group, which runs several restaurants in the state of Michigan. We will make your written testimony a part of the record. We ask that you please summarize your opening statements in 5 minutes, and I'll now recognize Mr. Holtz-Eakin for 5 minutes for his opening statement.
Well, thank you, Mr. Chairman, Ranking Member Pallone, Vice Chairman Burgess.
in light of the gentleman's comments prior to the panel, I do want to clarify first that I signed and submitted a truth and testimony form prior to testifying today, and it was executed truthfully. So I'm not sure what that question's about, and that the American Action Form itself is in compliance with all the best practice guidelines of the independent sector's principles for good governance and ethics, and certainly the legal requirements of the IRS as approved by this Congress. So I want to get that on the record. And lastly, when I say I testify, and these views are my own, the forum has associated with it a vast number of experts with areas of expertise ranging from energy policy to education policy to any number of things, and I would not pretend to speak on their behalf. And so these are my views as a researcher in both economic and health policy, and I want to emphasize that. I appreciate the chance to be here today. This is obviously a sweeping and important piece of legislation that arrives at a crucial moment in America's history, and that moment is one in which the top threat to our nation, both its economic prosperity and its national security, is the projected future deficits and rising debt that we see under any reasonable projection over the next 10 years. My reading of the evidence and what I lay out in my testimony is that if one wishes to produce simultaneously rapid economic growth, which I believe is an imperative given the large number of Americans who are out of work and the resources we will need to meet all our public and private demands, and bring the fiscal situation under control, one needs to follow the successes around the globe. And those successes are characterized by keeping taxes low and cutting government spending, in particular government payrolls and transfer programs, the kinds of spending that need to be cut. And from that perspective, the Affordable Care Act goes in exactly the wrong direction. It raises $700 billion in new taxes over the next 10 years and has $1 trillion in new transfer spending and would continue past that. And indeed, the more general point is that those deficits and debt represent a huge impediment to economic growth. They are a promise of higher future taxes or higher fewer interest rates or both, or in worst case scenarios, a financial crisis reminiscent of 2008. And I believe it's a mistake at this point in time to enact something like the Affordable Care Act, which in my view will make our fiscal situation worse, not better. It is past common sense to believe that you can set up two new entitlement spending programs that grow at 8% a year as far as the eye can see. That's the CBO growth rates. Tax revenues won't grow that fast. The economy won't grow that fast. And increasing new entitlement spending as a result will make our budget problems worse, not better. We missed an opportunity to fix our real problems in Medicare and Medicaid, and that's a huge part of my reservation about this law. Past that, I'll make a couple of points about the structure. So I laid out in some detail the structure of the mandates in the employer mandate in particular are an impediment to growth, particularly for small businesses, where we see the mandate kick in at 51 employees. And because of the nature of the phase-outs, if you hire a higher quality labor force, you get subject to greater costs. The insurance market reforms themselves, covering more benefits, will make premiums more expensive. The variety of insurer fees, taxes on medical devices and other things will raise premiums, not lower them. That will compete with other resources that could be used for hiring or increasing wages and will hurt labor market performance. And many of the new taxes, in particular the 3.8% surtax on net investment income, are of exactly the same character we've seen in recent debates over broader tax policy. They will affect small businesses, taxes passed through entities through the individual income tax, and as a result, something like $1 trillion of business income, which is reported on individual taxes, will be subject to higher tax rates and hurt economic performance. And so, as I tried to lay out fairly carefully in my written submission, the Affordable Care Act has costs that at this point in time I view as unwise for this country. It expands deficits. It imposes new impediments to firm-level growth, and more broadly represents bad economic policy at a time when we need to put a premium on growing faster as a nation. Thank you and look forward to your questions.
Chair, thanks, gentlemen. Recognize Mr. Cutler for 5 minutes.
Mr. Chairman, Mr. Pallone, and members of the committee, I appreciate the invitation to appear before you today. The high level and rapid growth of medical spending in the United States is an enormous policy challenge, and understanding how the Affordable Care Act will affect that is extremely important. As we consider that, there are two principles that I think ought to guide that discussion. First, we need to eliminate wasteful spending, not valuable spending, so we need to be careful about how we cut. Second, we need to reduce the overall level of spending, not simply shift costs from one payer to another. Many proposals would shift costs around without reducing the overall level of spending. The key question is finding areas where we can accomplish both of those goals, where we can both reduce wasteful spending and not just shift costs. The health policy literature suggests there are 3 areas where that is possible. One is by improving the management of acute and post-acute care for patients who are very sick and who receive more care than almost all physicians believe is necessary. Second is greater attention to prevention, where we spend a good deal of additional money by not having prevented disease. And third is reducing excessive administrative spending, which takes anywhere from 10 to 15% of medical care costs without bringing any commensurate benefits. To give you a sense of the total, most experts estimate that about $750 billion to $1 trillion a year is spent on medical care that has relatively low value to patients or no value to patients. The Affordable Care Act is designed to address those sources of inefficiency, and it does so in a number of different ways. The philosophy behind the Affordable Care Act is straightforward. First, get the right information to people so that we know what works and what doesn't. As one friend of mine told me once, name a business that ever got better without knowing what it was doing. One considers this it's important to note that the high-tech provisions of the American Recovery and Reinvestment Act of 2009 are centrally linked to those of the Affordable Care Act because they create the foundation for learning that information. Second, you need to reward doing the right thing, not doing too much, not doing too little, but doing the right amount. Physicians are frustrated not because they cannot treat individual patients, which they can, but because they know the system sends them off in directions that are counterproductive, that the only way to earn enough to keep their practice in business is to do more, to do things that are uncoordinated because coordination has expenses but no revenues, and to not focus on prevention. The Affordable Care Act affects these incentives in a number of ways, including direct payment innovations such as higher reimbursement for preventive care services, bundled payments for acute and post-acute medical services, shared savings or capitation payments for accountable provider groups that assume responsibility for a continuum of patients' care, pay for performance incentives for Medicare providers, increased funding for comparative effectiveness research, an independent payment advisory board, and an innovation center in the Center for Medicare and Medicaid Services to test and disseminate new care models, an excise tax on high-cost insurance plans to provide incentives to reduce wasteful spending there, increased emphasis on wellness and prevention. This set of policy reforms, I should note, is neither a Democratic list nor a Republican list. It draws on both sides of the spectrum. Former CMS or HCFA administrators from both Democratic and Republican administrations stressed these as the single most important steps we can take to reduce the amount of inefficient medical spending in the United States. In addition, in very little noticed provisions, the Affordable Care Act takes a major step to reduce burdensome administrative practices, particularly sections 1104 and 10909 lay the foundation for reducing administrative burden, which I believe could be reduced by half, and save the American people approximately 10% of medical spending simply by getting rid of administrative costs, not services that are no longer needed. The effect of these changes on medical spending, on federal and state budgets, and on job growth are profound. I estimate that when we are able to do this, the Affordable Care Act will reduce national medical spending by over $500 billion in the next decade, will reduce the federal budget deficit by over $400 billion, and lead to the creation of 250,000 to 400,000 jobs annually. The urgent need is for this Congress and the administration to work together on these ideas that are neither Democratic nor Republican ideas, but they're ideas that come from across the spectrum of thinkers and people in the healthcare sector, to work together to ensure that the Affordable Care Act is as successful as it can be. Thank you again for the opportunity to be here, and I look forward to answering any questions you might have.
The gentleman's time's expired. Chair thanks the gentleman and recognize Mr. Kennedy for 5 minutes.
Chairman Pitts, Ranking Member Pallone, and distinguished members of the subcommittee, thank you for inviting me to testify before you today on the effects of this complex and erroneous reform will have on my business. My name is Phil Kennedy, and I own Comanche Lumber Company, Incorporated, located in Lawton, Oklahoma. I'm here to speak to you on behalf of the U.S. Chamber of Commerce today. My family began operating Comanche Lumber Company in 1967. As Lawton grew, so did Comanche Lumber Company, eventually adding flooring and decorating products. What began as a simple lumber yard almost 44 years ago has become one of Southwest Oklahoma's leading building material retailers. Today, we remain independently owned and operated and a strong member and supporter of the Lawton community. However, the past few years have been difficult. As I wade through the new health care law, I began to grasp the mandates and their bearing on my business. I am deeply concerned about the future of my family's business. We have roughly 50 full-time employees, sometimes more, sometimes less, depending on the time of the year, because the bulk of our business occurs in the spring and summer months. Comanche currently offers a generous health plan to our employees. Over half of us take advantage of this coverage, including me. Comanche pays approximately 50% of the premiums for our employees and offers two different high-deductible plan options, one with a $1,500 deductible and another more comprehensive plan with a lower $1,000 deductible. Fortunately, we've been able to get good rates because of Oklahoma has good free market laws that encourage competition among insurance companies for my business. However, premiums have been climbing. In order to prevent large increases, we have had to make tough choices, which have included increasing our plan's deductibles and implementing a more tiered prescription drug plan. I understand the new law includes a number of new insurance rules billed as patient protections, which require free preventative services and place restrictions on annual and lifetime limits, among other things. While these new services may sound nice, we must realize they are not free. Instead, these new mandates will help hamper the flexibility to modify plans designs and restrict premium growth. Even with the flexibility we had over the past 2 years, our premiums have increased roughly 30%. There are many other aspects of the law that will increase Comanche's premiums, including numerous taxes on health industries, including taxes on medical devices, prescription drugs, and small business health insurance that will be passed on to me and my employees in the form of higher premiums. While these new insurance rules and taxes are problematic, their impact pales in comparison to what will happen when the new mandates kick in. Beginning in January 2014, businesses with 50 or more employees will be punished with fines if they don't offer a certain level of coverage. Even more troubling is the fact that businesses that offer a qualified plan that might still be fined just as much. It is ironic that the fine for businesses that doesn't offer coverage is $2,000 per employee, while the fine for a business that does offer coverage is $3,000 per employee, plus the cost they're paying for coverage. Considering that Comanche's profits are about 1%, I'm sure you can see how these fines would dramatically impact our business. It appears that to avoid these fines, I can either reduce my staff to less than 50 full-time employees or consider alternative staffing like employing part-time workers or outsourcing. I can't imagine why a law would incent these actions at a time when our economy is struggling to recover from such a terrible recession. But as a business owner, my job is to protect the business, keep the doors open, and sell building materials. I hope I will not have to seriously consider these choices, but the health care law may enforce my hand as well as that as many other small business people. Small business owners were hopeful that health care reform would rein in health care costs and bend the so-called cost curve down. However, looking through the bill, I don't see any real medical liability reform other than the vague acknowledgement that says states should be encouraged to develop and test alternatives. It seems to me that if we really want to address rising costs, medical liability reform should be tackled head-on. We need to fix the existing civil litigation system instead of merely saying it needs to be fixed. Real health reform would include ideas like this. Instead, the law just taxes, subsidizes, and dramatically increases my paperwork burdens by provisions such as the 1099 reporting. In conclusion, I understand that given the existing political realities in Washington, a total repeal of the health care law is an unlikely proposition for now. However, I'm hopeful that this subcommittee and your colleagues in the House and Senate will start on repairing and eliminating the most erroneous mandates and provisions, starting with the repeal of the employer mandate. Your decisions can either help or hinder us. The law you create can either foster an environment that gives small business owners greater confidence and certainty to grow and generate new jobs, or one that does just the opposite. Regrettably, the new health care law is already doing the latter. Congress must take action to rectify this problem. Thank you for the opportunity to testify and look forward to your questions.
Chair, thanks, gentlemen. Gentleman's time has expired. Chair recognizes the gentleman, Mr. Poore, for 5 minutes.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee. It's nice to see so many of you here. Thanks for having me to testify today. My name is Rick Poore, and I own Designware, a screen printing and embroidery business in Lincoln, Nebraska. I'm also a member of the Main Street Alliance, a network of small businesses, as well as the Lincoln Independent Business Association. I've been a small business owner for 17 years, and I started with 3 employees. Now we have 29. I offer insurance to my employees and pay for part of it. I'd rather have my employees worried about the product we're producing rather than whether Timmy can get his medicine and put food on the table at the same time. But every year our premiums go up, sometimes over 30% over the last 10 years. At the same time, in an effort to keep things affordable, our benefits were whittled away until we had nothing left but the insurance equivalent of a fig leaf. Only in the last 2 years have I been able to keep premiums under control without giving up benefits, and in fact adding benefits. The country counts on small businesses to create jobs. You hear it all the time. If you want to talk about job killing, you look no farther than the runaway health care costs that I've experienced. Small businesses' ability to create jobs has been seriously undermined by insurance costs, more than doubling in 10 years. We saw a lot of years of steep increases with no tools to do anything about it. Without a lot of choice and bargaining power, I stood a better chance at a Carney game at the Midway than I did against my insurance company. The Affordable Care Act is finally changing that in my favor. The argument that the health care law will cost our economy jobs ignores the lessons of the last decade, where it was the lack of action by Congress to curb skyrocketing costs, leaving small businesses in the lurch. The real threat to job creation is the threat of repealing this law and going back to a system that stacks the deck against me, diverting money away from investment and growth. Concerning the employer responsibility requirement, we've got to remember 2 facts. First, over 95% of our nation's businesses have less than 50 workers and won't be impacted. Second, 96% of businesses with more than 50 workers already offer coverage. If some larger businesses complain that paying for health coverage will harm their ability to create jobs, remember that when they don't pay, the rest of us pay their way for them, and that hurts my ability to create jobs. Imagine if my competition decided they didn't want to pay wages anymore, but I was held responsible for their payroll. That's effectively what we're doing with cost shifting in healthcare. Recent data from insurers in Nebraska, Kansas City, and national companies like United Health Group and Coventry show encouraging increases in small business coverage. The tax credits are already helping small businesses offer coverage, save money, and plow those savings back into their businesses. We'll get even more help when the exchange is open. I need that kind of broad risk pooling and bargaining power in a Nebraska exchange to lower costs. I know insurance lobbyists are trying to blame recent rate increases on the new law, but insurers find an excuse to raise rates every year. If they're raising them again, then it's in spite of the law, not because of it. Even insurance executives admit this. One in Massachusetts said recently that only 1 point of his company's increases this year were due to the new law. Small business people, in conclusion, above all, are problem solvers. We wake up every day looking for a better way to do our business. We take whatever pitch is thrown at us and we do what we can with it. My best employees become problem solvers for me. Problem solving is what Americans send you guys to Washington to do. And there's a funny thing about solutions I found is that most solutions aren't perfect right out of the box. You don't scrap them. You make a start in the right direction, and then you change course and correct the course as you need. One thing for sure, our country and our economy can't afford to go back to a health system that doesn't work for small business. I already know that it won't work. We've got to move forward. You know, when I was first approached about this, I had to think about what year I started the business, and I was talking to my wife, and as a habit, I don't think a lot of business people look back that much. I think they look forward as much as they can. There's just not a lot of time for looking back. So that's what I'm asking you guys to do. You can call it Obamacare if you like, but I kind of call it Rick Care. By moving forward, you can level the playing field for small businesses, allowing us to focus on creating jobs and building our local economies. Thanks again for having me, and it's something I'm not really used to doing. So thanks.
Chair, thanks, gentlemen, and recognize the gentleman, Mr. Schuler, for 5 minutes.
Thank you for this opportunity to testify in the new healthcare law on behalf of the National Restaurant Association. My name is Larry Schuler, and I'm an independent restaurateur operating a fourth-generation family business. Small businesses dominate the industry, with more than 7 out of 10 eating and drinking drinking establishments being single-unit operators. We also employ a high proportion of part-time, seasonal, and temporary workers. Our workforce is typically young, with nearly half under the age of 25. Growth and success in the restaurant industry means opening more restaurants and locations, which in turn mean jobs in our communities. When I closely examine the impact of this new healthcare law on my businesses, I began to re-examine my expansion plans and may now not take additional growth on. My written testimony submitted for the record outlines some specific fixes the industry is calling for, but I would like to use my time to outline for you how the new healthcare law affects my business specifically. My businesses are typical of many restaurants in our industry. We have a large group of seasonal employees that include a number of college students, some who work seasonally for us multiple times per year. We are very close to the 50 full-time equivalent worker threshold. How many hours our part-time employees work will determine if we are a large applicable employer or not. What this means for my restaurants and our employees that depending on the time of year and the number of hours worked by our team, we could be considered a large applicable employer and subject to the most stringent employer mandates in the law some months, but not in others. In addition, our employees could be full-time employees one month and part-time employees the next. Using our 2010 employment numbers, the calculations for our largest location would put us over the 50 full-time equivalent threshold. In 2010, on the average, we employed 33 full-time employees and 26 full-time equivalents working part-time hours, for a total of 59 full-time equivalents that place us over the threshold and subject to the coverage and penalty requirements of the law. We employed 24 seasonal part-time employees and 5 seasonal full-time employees as well, for a total of 38 full-time employees to whom we would be required to offer coverage under the new law as a large employer. Should all 38 employees opt into the coverage, we would see a 282% cost increase to the business over current premiums from $2,067 monthly dollars or $24,808 annually today to $7,892 a month or $94,669 annually. If we chose not to offer coverage at all, we would pay an average of $1,375 monthly or $16,500 annually in penalties. The penalties would be less than that what we are paying for health care now. Faced with these very large increases in coverage costs, which do not take into consideration the likely premium increases, it will be extremely difficult for us to absorb these costs and continue offering coverage. We cannot raise menu prices high enough to cover these costs, and to do so would drive away customers who are just beginning to return to our tables. Our only option would be to closely manage our workforce hours to be able to eliminate 10 full-time equivalents from our staff and remain below the 50 full-time equivalent large employer threshold. The industry will begin to closely manage employees' hours to 29 or less. In practice, it will mean a larger employee base, working less hours, no more than 25 hours to avoid bumping into the cap, and an increase in labor and training costs. For the employees, it will mean the need to get a second and third job to make up the lost hours and thus income. Another issue that impacts my situation is the lack of consistency in compliance timelines. The new law allows for a maximum waiting period of 90 days before coverage must be offered or an employer is considered as not offering coverage. However, a seasonal employee is defined as working 120 days or less. The new law requires that a large applicable employer offer seasonal employees who work full-time coverage. One of my businesses is strictly seasonal, open 107 days a year from the week before Memorial Day weekend until the week after Labor Day weekend. In 2014, I will be required to offer my seasonal full-time employees coverage from day 91 through day 107 or pay the penalty for that month on each of them for not offering coverage.
Could you...
Without legislation change, I would probably shorten the number of days. I would thank you again for the opportunity to testify today on the true cost of new health care law and its negative impact on the jobs of the restaurant industry and my business in particular. I look forward to addressing your questions.
Chair, thanks to gentlemen. I thank the panel for your opening statements. I'll now begin the questioning. Recognize myself for 5 minutes, and I'll start with you, Mr. Schuler. You mentioned you're considering closing your seasonal operation for a couple of weeks in order to avoid some of PPACA's requirements. You may continue to elaborate further on that.
Thank you. To avoid the complexity costs of being open those additional 17 days, it will be easier for me to manage the business to that shortened time period, so I will not be required to do that.
Mr. Kennedy, in your testimony, you mentioned that PPACA provides the wrong incentives for job creation at a time when we're still struggling to recover from recession. Specifically, you state that PPACA incentivizes you to get below the employer mandate threshold of 50 workers. Would you elaborate further on that, please?
We definitely would be considering that because of the new regulations and what that entails as far as health insurance. And we are currently even looking at as we go about making sure that what levels we have as far as employees, and that has become a decision factor in our progressing forward in growth. Whereas used to, we'd want to grow as much as possible. Now, as we grow above 50, we have another item we have to consider and how that would impact us as far as cost and whether those actual costs can be offset by profits that we make.
Thank you. Mr. Holseek, I would like to go through a few points regarding the score of PPACA to give us some broader context of what these numbers mean. And I would also like to explore what burdens have been imposed on taxpayers in states that, by their nature, wouldn't be reflected in CBO's score. CBO estimates that $86 billion in premiums from the new long-term care program known as the CLASS program are used to offset the cost of the new entitlement and Medicaid expansion in PPACA. Can those funds be used to pay for both PPACA and future CLASS program benefits?
No, they cannot. They'll be gone in the first 10 years, and additional funds will have to be found after that.
All right. CBO estimates that $53 billion in Social Security payroll taxes are used to offset the cost of the new entitlement and Medicaid expansion in PPACA. Can those funds be used to pay for both PPACA and future Social Security benefits?
Same story is true. Those will be gone in the first 10 years, and additional funds will be need to be found to make good on Social Security promises.
Now, some proponents of the law have claimed that Medicare cuts included in PPACA can both pay for new entitlement spending and finance future benefits. Is this an accurate statement? Would you elaborate on that?
It's not accurate. Federal accounting notwithstanding, the money will be spent only once and cannot both extend the Medicare program and pay for the insurance subsidies.
Proponents of the bill argued that PPACA cost under $1 trillion over 10 years during its passage. However, the CBO score of the bill was artificially low because the other side of the aisle delayed the bill's major spending until 2014. Now, we recently found out that With just 2 more years of spending, PPACA's spending estimate shot up to $1.44 trillion. However, this number still doesn't account for the full 10 years of implementation. If we extrapolate CBO's estimates to the full 10 years, what would you estimate the real cost of the bill to be?
I think over a full 10-year, fully implemented, this bill is easily going to exceed $1.6, $1.8 trillion.
All right. The original House health care bill included the doc fix, but the provision was taken out towards the end of the process. This is despite the fact that PPACA uses Medicare cuts to fund a new entitlement program rather than fix the SGR that we all agree is a real problem. How much did the removal of the SGR artificially lower the cost of health care law?
As I recall, it reduced it by about $250 billion over the first 10 years.
How much?
By about $250 billion over the first 10 years.
And the score for the health care law also did not include nearly $115 billion in the discretionary program cost to run Obamacare. Is that not correct?
That is my understanding, yes.
All right. Chair thanks the panel, and will recognize now the ranking member, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I'm going to try to get one question in for Mr. Cutler and one for Mr. Poor, so let's bear with me if we can try to split the time between it. Let me start with Mr. Cutler. Opponents of the Affordable Care Act claim that the law will kill jobs. They argue that requiring employers to offer health insurance and to improve their benefits will increase the cost of labor. Now, I don't think that's true. I think that, in fact, the Affordable Care Act helps to create thousands of jobs in the public and private healthcare sectors. In June 2010, funds were allocated to train more than 16,000 new primary care providers, including physicians, physician assistants, and nurses. It seems logical that the newly insured 30 million people will need doctors, nurses, and other healthcare personnel, I should say, to meet their medical needs. Now, the Republican critics say they fear the country may not have enough doctors and hospitals to serve those people. But my answer is a growing workforce, more jobs, and improved efficiency. Specifically, less spending on healthcare premiums will free up money for business to invest in a new workforce. Now, the CBO said today that to the extent that changes in the health insurance system lead to improved health status among workers, the nation's economic productivity would be enhanced. Dr. Cutler, you've done work on what effects the bill will have on the job market. Your study predicts that the health reform will strengthen the economy and the job market by creating 250,000 to 400 jobs a year for the next decade. I just want you to elaborate on your study and explain to us how the health care reform is a job creator, not a job killer, and talk about some of the other factors that I mentioned.
Thank you, Mr. Pallone. Health insurance costs are an absolutely critical indicator for hiring. Industries in which more businesses are providing health insurance to their workers have grown less rapidly than industries where fewer employers provide health insurance, and that is particularly true in the United States in comparison to other countries. And so the fundamental issue about any health care reform is what will it do over time to the cost that businesses face for health insurance. As I discussed in the testimony and in the opening statement, the Affordable Care Act contains essentially all of the tools that economists and policy analysts have put forward for reducing the cost of medical care over time. It's my belief that what those provisions will do is to reduce premiums by the end of this decade by about $2,000 per person relative to what they would have been. That will free up money for firms that are now providing insurance, that are thinking about providing insurance but are on the margin, and allow them to take that money and use that to grow businesses, to pay higher wages, to do any of the things that businesses would like to do that they've been stifled from doing. In addition, by creating a universal coverage system, we will no longer have people locked into jobs because they are worried about getting insurance or not starting new businesses because a member of their family is ill and won't be able to afford it. And all the rigidities that come from people being scared about health care, which is very common, will disappear, and that will create more entrepreneurship in the economy as well.
All right, thank you, and thank you for also limiting your answer so I can get to Mr. Poor. Mr. Poor, Rand estimates that small businesses will increasingly offer health coverage now we're talking about the Affordable Care Act. RAND estimates that small businesses will increasingly offer health coverage because they will have the same purchasing power as large employers, as well as access to more choices. It also reports, RAND reports, that the Affordable Care Act will increase the number of small employers, with those under 50, who offer health insurance, up from, say, 57% to 85%, okay? So basically they're talking about all the different advantages that the Affordable Care Act would provide. A lot of this comes from the state exchanges once those state exchanges are up. So I just wanted you to describe how you think these state exchanges will affect your business and other small businesses in the country.
Well, first of all, I think that we're already starting to see more small businesses getting coverage. Statistics are showing that from Coventry and several other large people cover. But for me alone, every year my insurance guy would come in and say, listen, your rates are going up 16% or 23%. And I'd say, you know, Troy, why is that? And he's like, well, you're just a little group, you know. And so, Troy, if I had 10,000 people in my risk pool, would my rates go down? Well, absolutely. So that's where the exchanges come in for me. You know, if I can shop and get, you know, once again, just going back for a minute, Troy would also come in and he'd give me 2 companies, 3 plans from each, you know, and that was my choice. You know, but a big company or like a service employees or not service employees, but like a public employees, the state offers this broad, they almost already have exchanges running that I don't have access to. So I'm kind of hamstrung that way right now. In the last 2 years, I've been able to like keep my rates from going up. I've actually added some benefits. My rates have gone up over 2 years, 16%. That's the lowest increase in rates that I've ever seen in 11 or 12 years offering insurance. Now, and the only reason they went up is because I was putting I was lowering my deductible and I was lowering my out-of-pocket. So if I'd left it the same, I might actually be level, which, believe me, if there's anybody that's ever, I know these gentlemen have, I've never had a situation where my rates didn't go up. It's a pretty phenomenal statement to be able to make.
Thank you.
Gentleman's time has expired. Recognize myself for 5 minutes for the purpose of questions. Mr. Holtzeek and Mr. Cutler, you've both been at this a long time. You both remember the summer of 2009, specifically August of 2009, my little sleepy town hall meetings that I would hold that typically attracted 1 or 2 dozen people, attracted 1 or 2 thousand people. They were concerned about what they saw the Congress of the United States doing, but what I heard over and over again was, number one, if you're going to do anything, please don't mess up what is already working for arguably 65% of the country. If you have to fix some things for some people, do so without being disruptive. And number two, if you're going to do anything at all, could you please help us with costs? So I would ask you both to be as brief as you can, but how did we do on those 2 requests? Mr. Cutler, if you'll go first, and then we'll go to Mr. Holtzeek. Did we mess it up for people, and did we hold down costs?
I believe we did very well on both counts. I believe.
All right, let me ask Mr. Holtzeek. How did we do on both counts?
I think you're 0 for 3, actually.
0 for 3. We only had 2. Well, Mr. Cutler, let me just ask you, I mean, how is it indicative that we didn't alter the system for people who thought it was working, arguably thought it was working okay, although they're concerned about costs, but now we've got, 1,040 waivers? We've got whole states asking for waivers? We've got Anthony Weiner in New York asking for a waiver, for crying out loud? Is this indicative of a system that is well-functioning and has matured to the point where you think it's in good shape?
What we're seeing is the difficulties of the current system as they're being mapped out. Remember, this legislation takes effect over a number of years.
Correct.
Mr. Poore said the creation of the exchanges will be a very big,
let me ask you another question.
Very big factor for small businesses, but those come in a few years.
Well, Dr. Holtzeek, do you have an opinion as to the system working well?
No. I mean, in the end, the fundamental issue was the size of the nation's health care bill. Insurance is just a layer on top of that. And so you could have the world's finest insurance exchanges, but we haven't solved the fundamental problem. As a result, insurance will continue to get more expensive, and that is what the American people are upset about.
You know, one of the things I never understood, we'd have these hearings when Mr. Pallone was chairman, and people would come in and talk to us about expanding Medicaid and the various federal programs and public options. We never asked Mitch Daniels to come in here and talk to us about how he was able to hold down costs for his state employees with the Healthy Indiana plan by 11% over 2 years. Those same 2 years, standard PPO insurance was going up 7 or 8%. Medicare and Medicaid, as it turns out, retrospectively, were going up 10 and 12%. You just have to ask yourself why you wouldn't look to the states as laboratories and find out what's working and see if perhaps there's some applicability to the greater world at large, and perhaps we wouldn't be so disruptive to Mr. Kennedy, Mr. Schuler. Mr. Poore is apparently doing okay with the system as it is written today. And Mr. Cutler, you were a fan of the Independent Payment Advisory Board, but you know virtually everyone on the House side was not. And in my opinion, the Independent Payment Advisory Board really is indicative of one of the problems with the Patient Protection Affordable Care Act, in that the House bill, as bad as it was, never got a fair hearing in a conference committee. The Senate passed a bill before Christmas Eve. They lost a critical Senate vote in Massachusetts 2 weeks later, and it was, you just got to pass this thing in the House. And as I alluded to earlier, the Senate bill did have a House number. It had previously passed the House as a housing bill, so that actually structurally was able to work. And also conveniently, since there was a lot of tax increase in the bill, it started in the House of Representatives technically, although it actually did not. But what do you make of the Independent Payment Advisory Board now? You said it would be apolitical, and yet you got groups that are opting, or politicking to be left out of it. Is it working?
One of the issues with Medicare has been that it's been very difficult to make the program modernized when every single change has to go through the Congress at a glacial pace. And I think that's been a complaint from both sides of the aisle.
But in expediting, by saying if Congress can't agree what those cuts are going to be, they reject the current cuts that are presented, they can't come up with their own cuts. And on the following April 15th, the Secretary just implements what the board put forward. I don't know. That's giving up a lot of constitutional authority that I think many of us, at least on the Republican side, have problems with. And I rather suspect our friends on the Democratic side of the dais had difficulty as well. Cost shifting, yes, the uninsured, Dr. Holtz-Eakin, caused some cost shifting, but what about the cost shifting from Medicare and Medicaid, and what did we do with the vast expansion of Medicaid into the Affordable Care Act? Are those people going to have a doctor, or are they still going to show up the same emergency room they've always gone to?
I think, CMS Actuary Foster evinced some concern about the future in Medicare about access to providers, given the cost shifting that goes on there, 70 cents on the dollar relative to private payers. I'm deeply pessimistic about the future of Medicaid, where outside of the near-term federal pickup of the tab at 50 cents on the dollar, we're simply not going to see access, particularly to primary care physicians, and we know they show up in ERs at far too high a rates. So to use that as the mechanism for coverage expansions, I think, was one of the unwise choices of the Act.
Yeah, why wouldn't they show up at the ER? It's the same place they used to go when they were uninsured. They see the same doctor. They get the same hospital room. In fact, many will not even sign up for Medicaid because why go to the bother? It's what I've always done is go to the emergency room and get the care. My time's expired. I'll recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes.
We in Louisiana have great affection for Bo Pelini. I wish you all the best in the Big Ten.
It's been great.
As long as you don't play LSU, we're rooting for you, buddy.
It's been great. Great guy.
Listen, how many employees do you have?
29.
As I read this bill, if you have 25 employees or less, average income of $25,000, you get a 50% tax credit.
I should fire 4 of them.
And if you lose 4 of them by whatever reason, would you go back up to 29 and lose this tax?
Absolutely. I can't do the business I've got right now.
Okay, that's good. Others tell me differently, but thank you for your response. Mr. Cutler, and if you're a PhD, I apologize. It didn't indicate.
Turn your mic on.
And yet earlier when I was speaking with Mr. Foster, he accepted the premise of that 2008, I think, Milliman article, that there is an hydraulic effect, particularly as we see the Gingrey chart, where there is this cliff, and there's going to be this inevitable increase. In fact, I'm struck in Nebraska, they're estimating that in 2014 to 2019, there'll be 189 million increased dollars spent on Medicaid in Nebraska, so undoubtedly an increased tax burden. You just disregard that. I'm not quite sure why.
Thank you for the question. What we've seen in the past few years in both Medicare, Medicaid, and private insurance is that the number of services people receive goes up, and as a result, governments and private insurers lower the rates that they pay. What will work in the healthcare system is to run that in reverse, to figure out which services are not worth.
So you're postulating that we're going to become more efficient in delivery of care.
More efficient.
And even though we're taking out, according to that cliff, we're going to pay physicians 31% less than they're currently receive, somehow we're going to be held harmless.
Our best guess of most experts is that at least 1/3 of medical spending is completely wasteful, and the answer...
Now, I'm struck as well, just because we're short of time, I don't mean to be rude. Obviously, if we could pick out that 1/3, wouldn't it be great? Mm-hmm. It's just so hard to pick out that 1/3. I'm a practicing physician. I still see patients. It's that 1/3 that's critical. Eye of the beholder, if you will. Do you see accountable care organizations as being one of the mechanisms by which we squeeze out this waste?
I do believe that is one of the mechanisms.
Now, I'm struck that there is an article published, frankly, last week in the New England Journal of Medicine, and in which these people look at the accountable care organization and says that basically, looking at the CMS demonstration project, which was structured, frankly, to find a positive result. And indeed, they found that over 3 years, they all lost money. 8 of the 10 in physician groups in the demonstration did not receive any shared savings in the first year. In the second year, 6 of 10 did not. In the third, half of the participants were still not eligible. And they point out that these were structured. These were already existing groups. They had gamed the system to have a positive result. They all lose money over the first 3 years. I don't see these ACOs as this huge efficiency-generating cost savings. This article suggests not. Why do you hold that position?
What we know is that some organizations are able to do extremely well, including if you look at, say, the Mayo Clinic or the Cleveland Clinic or Geisinger Healthcare.
Which I think were included here. Certainly Geisinger was.
No, those tended not to be in those organizations. Most of the demonstrations were not there. So those organizations have figured out how to improve the quality of care and save money. Other organizations are still learning how. The failures are generally because they don't have the right information systems in place, because they still work off a fee-for-service payment basis, and so the doctors still know that doing more is the way you earn more, or because they haven't figured out how to efficiently manage the practices that are involved.
Excuse me, I'm not seeing the list of people here, but I actually think it has groups that were well established. And so, but I do think I'm taking from you that what you're arguing is a theoretical benefit, nothing that has been actually demonstrated. If you will, it is the hope by and by, but it is not the experience currently.
Actually, it is the experience of a number of organizations across the country.
I haven't seen that data, and this is a review of those CMS demonstration projects. If you can refute this article, I'd appreciate that.
The Institute of Medicine just published a lengthy volume in which they went through a number of the successful examples, and they estimated...
I've not seen a single ACO article that suggests that, but please forward that.
I will indeed.
Secondly, regarding preventive services, again, I'm a physician. Preventive services have never been shown to save money unless it's immunizations or maybe the management of obesity by increasing premiums for those who don't lose weight. This article actually vitiates that ability. And so when you postulate that preventive services will save money, there's no empiric data for that.
There are different kinds of preventive services. The ones which clearly save money are, for example, tertiary prevention. That is, someone's in the hospital with congestive heart failure or COPD. We know that if you visit them if a nurse visits them within a couple of days after the hospital, they're less likely to be readmitted in the hospital. You can take the readmission rate.
For your testimony mentions colonoscopies, cholesterol checks, but that hasn't really been shown. You're speaking about reducing readmission.
Some of those, if you look at the studies, actually do save money. Some just extend life, but don't.
Which of those would save money? because colonoscopy does not. I'm a gastroenterologist, and so
obesity reduction saves money.
Now, the obesity reduction actually saves money, according to people like Safeway, by increasing premiums for those who do not enter into a weight loss reduction program. But I'm struck that the PPACA basically does away with that. And so it seems like you're endorsing something which PPACA does away with.
I'm not sure I agree with that. The Affordable Care Act has the discount for wellness management, 30%, or which can increase to 50%.
I don't recall. So I'll look at that, and if I'm wrong, I'll stand corrected. But it's my understanding you can no longer decrease premiums for those who do not participate in the stop smoking or obesity reduction. But if I stand corrected, I will be. Thank you very much.
Gentleman's time has expired. Chair recognizes the gentleman from Georgia, Dr. Gangry, for 5 minutes.
Mr. Chairman, thank you. I'm going to address my first question to Mr. Cutler. Is it Mr. Cutler or Dr. Cutler? Or?
I'm officially a Dr. Cutler, but I'm happy either way.
Well, the brain power sitting at the witness table, I feel a little sheepish calling any of you Mr. unless you're Brits. But in any regard, I will address my first question then to Mr. Cutler. In the March 2010 Wall Street Journal op-ed, you wrote that there have been several broad ideas offered to bend the cost curve over the last decade, including medical malpractice reform. As you might know, I have a very keen interest in that as a practicing physician and member of Congress. Do you believe that this Congress, unlike the last, should finally address medical malpractice reform, and what is its potential impact on health care cost?
There are a number of areas in which I think the legislation could be strengthened, and that's one where I personally would strengthen the legislation some. Most of the estimates of the impact of malpractice reform on medical spending suggest that the direct spending impact and the reduction in defensive medicine would be relatively small, on the order of 4% or so. What I think it is important for is in sending a signal to physicians and the physician community that we are serious about freeing them to practice care in the right way, not in the way that just earns you money.
Well, let me move on that same question then, Mr. Cutler. I move to Mr. Holtz-Eakin, our former CBO director, and ask really the same question, Doug. What Mr. Cutler said doesn't really jive with what I think my fund of knowledge tells me in regard to defensive medicine and the actual cost. I mean, even the CBO, Mr. Elmendorf, said $54 billion over 10 years. That's a lot of bread, but I think it's a lot more than that. I think it could very easily be $150 billion annually, because some of the doctors on the panel on the Energy and Commerce Committee could tell you in their practices how much ordering of very expensive imaging procedures in particular, and drawing a lot of blood. I could go on and on and on, but yeah, I'd like for you to comment on that same question.
This issue's been around for a long time. I think there's no question that malpractice reform should be on the table. That's indisputable. How much would come out of the nation's health care bill really revolves around the degree to which practice patterns have been dictated implicitly by some defensive medicine driven by lawsuits, or if it's really just the way groups practice. And so new doctors come in and they're told, this is the way we practice. Is that really just a matter of caution, or is it deeply embedded in a reaction to the legal environment? We don't know how big that will be, and that's been the conundrum for a long, long time.
Well, the President, of course, has promised, and we hoped that there would be something in Affordable Care Act. There was not. We heard earlier testimony that this would save a tremendous amount of money. I don't know what the true value is, but I think it is time for us to get that done. Mr. Holtz-Eakin, I'm going to stay with you. Proponents of this law argue that the bill will help reduce the deficit in the second and third decades of implementation, not just this first 10-year period. Doesn't this claim rest on the assumption that the dramatic reductions in Medicare and massive tax increases on employer-sponsored health coverage of working-class America stays in effect? Can you explain how ever-increasing taxes are used to offset the massive increases in spending that are contained in the Affordable Care Act?
Yeah, at the heart of it is the notion that, you know, the spending will go up as we've seen these long-term projections for Medicare and Medicaid go up for a long, long time. CBO's put these out, and Medicare and Medicaid go up from 4% of GDP to 12 or 20% over the next several decades. And for a long time, the presumption has been, by any reasonable analyst, you cannot tax your way out of that problem. You have to take on the spending. What the Affordable Care Act does is essentially recreate that spending and promise to tax its way out of it. And I don't view that as a plausible economic proposition. We're not going to raise the Cadillac tax so high to make this balance over the long term. You've got to control the growth of spending. And no analyst outside of David has come in and believed that this controls the spending growth.
Mr. Cutler, you're shaking your head. I've got 20 seconds left if you'd like to weigh in on that. I'll cut you off if I decide to, but go ahead.
If you look at what the Business Roundtable has said, they said that this way of making reforms would lead to big changes in cost savings. If you look at what the American Medical Association has said, what the American Hospital Association has said, what the Association of America's Health Insurance Plans have said, all of them have said that this is the way to go and that they believe that this is the potential for saving enormous amounts of money.
Well, that might be true with a policy like this, you end up forcing all of the doctors who practice privately to sell their subspecialty practices to large charitable hospitals who bill under Part A rather than Part B, and eventually then the federal government will have control over the whole ball of wax, and then we'll have national health insurance. I yield back, Mr. Chairman.
Chair thanks the gentleman and recognize the ranking member, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman. Mr. Poore, I want to ask you a question. As we heard today, the U.S. Chamber of Commerce prides itself on being the world's largest business federation representing the needs of businesses, large and small alike. But it seems to me that when the Chamber accepted $86 million from the health insurance industry, companies such as Cigna and United Health Group, to lobby against health reform, it gave up any credibility it had to represent small businesses. The small business majority released a study to demonstrate what would happen to small businesses without health reform. The findings show that 178,000 small business jobs, $834 billion in small business wages, and $52 billion in small business profits would be lost due to high health care premiums, and over 1.5 million small business employees would continue to fall victim to job lock. The Chamber claims to represent small businesses, then why does it oppose health reform provisions that would prevent small businesses from facing these challenges? Do you feel that the U.S. Chamber of Commerce represents you as a small business owner?
To be honest, no. For mainly the reason you gave. I've never had a national commerce guy call me, but I don't have $86 million in the bank either. Yeah. So to be frank, I really don't believe that. I mean, they lost their credibility when they did that, when they accepted money from the insurance lobby. Now,
then they're no longer representing businesses.
In a lot of ways, I don't think.
But I want to use my time to ask another question, and we're limited in time. But I thank you very much for your contribution to this hearing. We're once again, after we've talked about the Affordable Care Act, which is a bill that reduces the deficit in responsible ways, extends coverage to over 30 million people, while freeing people from job lock and fighting insurance company abuses. We're now hearing from the Republicans whose next step is to undermine health reform by destroying its foundation, the Medicaid program. The Republicans are about to unveil a budget that, by all media accounts and statements from Republican Budget Committee members, will block grant Medicaid to create hundreds of billions of dollars in savings, some reporting as high as $850 billion. At the same time, we can expect the budget to extend the Bush tax cuts permanently. The exorbitant price tag for extending those cuts just for the wealthiest Americans is a striking $950 billion. The current Republican majority is not serious about deficit reduction. They are about ideological stances that help the rich get richer while the middle class and poor are attacked from every side. Who is it they're targeting in the Medicaid program? 30 million children, 14 million seniors and persons with disability, 1 million nursing home residents, 3 million home and community-based care residents, all who are relying on Medicaid. And Medicaid is an efficient program. It costs per enrollee Medicaid cost per enrollee growth was 4.6% between 2000 and 2009. That's slower than premiums in employer-sponsored insurance and national health expenditures. Current Medicaid spending increases criticized by the right are merely because the program works as intended to help people who have lost their jobs and health insurance during the recession, not because of excessive cost growth on a per enrollee basis. Hundreds of billions of dollars in cuts to Medicaid is a blind axe that will merely shift costs to the states, to providers, and mostly to beneficiaries who will go without care. Dr. Cutler, can you talk about what such large cuts in Medicaid would mean for states' economies, for families, and for providers?
I think cuts of that magnitude would be catastrophically bad. If you run through this past recession, the Great Recession, without the ability to expand Medicaid by having the federal government be able to do that, you would have produced millions more uninsured people, people suffering lack of care, substantially worse health outcomes, hospitals and physicians that go under because they're overwhelmed by the number of uninsured people. And at the same time, you would have not achieved any real reductions because the block grant itself does nothing to actually figure out how to run the system better. What we need to do is save money in Medicaid and throughout the healthcare system by running systems better, not by just shifting costs and making bad times be even worse.
And in order to pay for this program, which has been a successful program, I mean, it's a lifeline. It's a safety net program. In order to pay for this, we're refusing to ask the people at the very top, 1%, to pay their fair share of taxes, so the people at the very bottom will just be thrown to the bottom of society without access to the care they desperately need.
A very large share of economists agree that over time we need to reduce medical spending and to raise revenue, particularly from higher income people whose incomes have gone up a lot. Those two facts are not in much dispute.
Thank you very much. Thank you, Mr. Chairman.
The gentleman's time has expired. In conclusion, I would like to thank all of the witnesses and the members that participated in today's hearing. This was an excellent panel. I want to remind members that they have 10 business days to submit questions for the record, and I ask that the witnesses all agree to respond promptly to those questions. Thank you. This subcommittee hearing is now adjourned.
Mr. Chairman, we'll hold the record open for your comment on the policy for the committee for the future on
We'll give you that in writing if I understood that the staff had talked to your staff about that.
Without objection, could we just put it into the record and we'll look forward to getting it in writing?
Without objection, so ordered.